I clicked it to allow. See if it works for you. You want to change the connection? Ron, you upset? Did you disable the Wi-Fi? When I rebooted the Wi-Fi, my phone, you have to disable it. What's happening? I'm supposed to show this, and instead it's showing this screen. Five minutes. 5 minutes, thanks. Beautiful. Okay. have a chat shortly. Let's get the microphone going. Here, yes, good. Oh, but that's good. Okay, cool. Morning. Morning, everyone. Welcome. Hi, everyone. Sorry we're getting started a few minutes late. Minor technical glitch. This is also going out as a webinar, so there are optometrists around the U.S. and actually in 5 countries who will be seeing this presentation. So some are getting credit, like us. Some people scattered around the world are not getting credit, but it reinforces a great point, which is it's not always about the credit. Sometimes it's about the content and about just your own knowledge and raising your standard of practice, and that's what we're seeing. Actually, we're getting seeing that around the world today. So very, very good. Anyone watching online, thank you for allowing us a few minutes to get set up. If there are any issues that you notice, please just report them in the chat. We'll correct them immediately. That is being monitored as well. So good morning. I'm Dr. Alex Kabiri. This is Dr. Devin Singh. Yeah. And we work here in New York. This is year 16 for me in practice. I've been with the practice for 4 years now. Great. It's a group ODMD practice called Malik Eye Care. 1 office in Manhattan, 1 in Long Island, 3 in Queens. And what grew from 1 office with a satellite location 10 years ago, it has now grown to 5 offices with 11 doctors. So it's been a lot of good growth. And largely because, we really practice, really take it to the hilt. We do everything that we can do, and we do it as comprehensively as we can, very efficiently, without being neglectful in any way. So we're happy to, take some of that and share it with you today. Okay, so today our first lecture today is going to be on ocular inflammation. We're going to examine various ocular pathology, but we're going to look at it from the standpoint of inflammation. Sure. First we'll start with the definition of what is inflammation. It's redness, swelling, and pain to various parts of the body, organs, and tissues. It's generally brought on by injuries or surgery. Sure, injury, infection, surgery as a controlled injury, we could say. And it's funny because sometimes we think of inflammation as, well, the patient comes in with a beet red eye, complaining of photophobia perhaps, and if they don't have these signs or symptoms, then we might not always think of inflammation. But we'll get into a little bit about how that may not always be the case. First we'll start going back to in school, how does inflammation occur? It typically, like we said, starts with an injury and infection. The cell membrane will release phospholipids that get disrupted. And we know certain enzymes will now convert that phospholipids to arachidonic acid. And arachidonic acid is the precursor to most pro-inflammatory molecules. And it's important to know a bit about the pathway, because the different therapeutic options that we have, well, they act at different points of this pathway. And one thing that we'll get to later on is, well, if, for example, if steroids act up here, if steroids act higher along the blocking the arachidonic acid conversion, then and non-steroidals act further down the cyclooxygenase pathway, why do we need both? Sometimes after surgery, why does it make sense to have both? Why doesn't the steroid just do everything and there's no real role for the non-steroidal? So we'll get to that as well. Yeah, we're going to examine the 2 major branches of the pathway. Down the lipoxygenase pathway, it's where you recruit your white blood cells. The cyclooxygenase pathway is where you get your inflammatory mediators that trigger redness and swelling and pain. In the cyclooxygenase pathway, you have a release of prostaglandins. Prostaglandins mediate the pain response through increased vasopermeability, leading to swelling and redness. Sure. And when you think of going further down, you have the lipo-oxygenase pathway producing leukotrienes, activating leukocytes like neutrophils, eosinophils, basophils, lymphocytes, and also affecting vascular permeability and bronchoconstriction. When we think of all the different cell types involved in inflammation, neutrophils, eosinophils, basophils, lymphocytes, it's nice to know where they fit in, but in terms of your management plan, if you don't remember the immunology too well, it doesn't mean you can't actively, engage in managing inflammation. So we'll talk a bit about that.
Now, going back to the initial slide, we talked about how phospholipids are converted to arachidonic acid, and arachidonic acid is the precursor to most pro-inflammatory mediators. And why steroids are so powerful is because they inhibit the production of arachidonic acid. So as you see, by cutting it off with this arm, you prevent the release of all the different pro-inflammatory mediators. Whereas NSAIDs, they target specifically the cyclooxygenase pathway. So you still allow the body to, for example, fight infection by not suppressing your white blood cells. Sure. At the same time, you're still able to target symptoms like the pain, swelling, redness.
Sure. So just quick show of hands, and for those of you who are not in the room but you're watching remotely, just think to yourselves, anyone here actively prescribing NSAIDs when you see ocular inflammation? Maybe perioperatively, but outside of that, anyone really using NSAIDs for anything?
Yeah, for allergies.
For allergies, right? That's a good point. We'll definitely get to that point. Anyone else using NSAIDs for allergies? Probably not too much, right? Maybe here and there, but we'll talk about where that fits in. And any questions? We have a small, intimate group in the room, but definitely jump in where you can.
Yeah, we'll try to keep it as informal as possible.
So the next slide that we have here, this shows the inflammatory cascade, and what we love about this particular slide is that we often see bits and pieces of this. Sometimes we see up here in the top left, let's say, where we're showing where the T cells become active. Well, around dry eye, we think of that. We think of products like cyclosporine, lifitegrast, as being active up in this area. So we've probably seen bits and pieces of that pathway represented to us. Up here, where we see the mast cell degranulation, well, we've seen the release of mast cell, histamine into the intercellular space as part of the allergic cascade of events. So we've seen bits and pieces of this pathway broken down as well. And then, as Dr. Singh had just shown on the previous slide, as we move down to the second tier here, we see the phospholipase conversion, to arachidonic acid. We see this pathway here as where steroids act. And then, if we come even further down to the lower right, we get to where non-steroidals, work down here. But for myself, I had never really been able to put it all together and see it all put together and get an idea of where all these therapeutic options fit in, where they overlap, where they don't, and sometimes why, when you might prescribe, let's say, an allergy product for a patient, they might come back and feel great. You might prescribe the same allergy product for a different patient, they'll come back and say, it's kind of okay, I kind of don't feel that much better, it still bothers me, and you're not really sure why it didn't work. Well, there was some other stuff going on, and a second agent, or perhaps choosing a different agent that had a wider spectrum of activity based on the receptor affinity profile of that product, could have maybe alleviated the patient's symptoms more.
For example, with a lot of allergies, depending on whether it's acute or chronic, we know with chronic inflammation, we have a presence of our T cells. And what I like about this slide is that it demonstrates how T cells play a role in inflammation, including with allergies, and why steroids will have a role in treating allergies.
Absolutely.
Especially when it's chronic.
Absolutely. You might have seen on TV, there's a commercial for a product. I don't remember the product, but I remember the commercial where they show a patient that has allergies, and they say, 6 is greater than 1. This particular product blocks all 6 pathways involved, whereas antihistamines block only 1. So, you can see here, well, you'll see on a subsequent slide that in that situation, what are the 6 pathways that are blocked, and why sometimes an antihistamine product alone for a patient with allergies may not be enough.
Any questions so far?
Anything, questions, comments, jump in anytime. Everyone here is
also, for our online audience, any questions there, you can enter it in the chat, and we'll gladly answer it. Yes?
Is it also effective for CMV, cystoid macular edema?
Is what effective?
Steroids.
Non-steroidals. NSAIDs more.
And then we're going to go into why that's the case too later on.
So for those online, the question had to do with CME and steroids and/or non-steroidals, and we'll touch on that a little bit later.
So now we're going to talk a little bit about NSAIDs. You know, we mentioned previously that NSAIDs target the cyclooxygenase enzyme. That enzyme is actually broken down into two further branches, our number 1 pathway and number 2. When we're treating therapeutically, we're looking at, you know, how effective it is at targeting the number 2 pathway. Number 1 basically plays more of a role with doctors treating patients with oral histamines that will, you know, potentially affect their stomach, cause gastric upset, or it can affect the platelet count. But for most NSAIDs that are used to treat pain, they have a stronger profile towards the number 2 pathway because they target prostaglandin synthesis.
All of the newer non-steroidal topical ophthalmic products are COX-2 selective. So
interesting also, a lot of patients who are taking, you know, oral NSAIDs for chronic pain, arthritis, you know, various other pathology, you'll oftentimes see that they're also taking an H1 blocker for their stomach. They'll complain saying they have gastritis. It's always worthwhile to inquire, are you taking your pain medication?
definitely. So a little bit about the history of non-steroidals in eye care. Going back to 1986, Ocufen was the first one approved for preventing intraoperative miosis. Voltaren was approved for postoperative pain around cataract surgery, and then of course Acular, which we're all familiar with. You know, Acular, before it was approved for post-op inflammation, it was actually approved for allergy, and that's where this comes from. So, you know, initially when the studies were done with ketorolac around allergy, you know, it was compared to placebo, and yes, it did reduce itching more than placebo, so it got the indication. But once the topical antihistamines came out, they were much more effective at reducing itching than the topical NSAID ketorolac was. So it didn't really remain a dominant player in that stage of the market. So they then took the same product and pursued post-operative indication, which they obtained and kept it viable. But it doesn't mean that it's useless for allergy, as Dr. Obi mentioned. Definitely.
Yeah. And also, this nicely illustrates why, you know, in school and in clinical practice, most of us predominantly use NSAIDs topically with surgical patients because that's where their history stems from.
True.
But as is the case with allergies, and possibly in the future, you know, other pathology, they may play a role as well.
And it makes sense too, because if you think about it, when you have a cold, or when a patient has severe allergy, some of the products do also contain a non-steroidal, an antihistamine and a non-steroidal. So it makes sense that there's room for a non-steroidal when you're managing these patients, even outside of cataract surgery sometimes.
Now we're going to start by looking at various types of inflammation in various parts of the eye. We're going to start more superficially with the lids. We've all seen a case or two of presubtle cellulitis. There you have diffuse inflammation of the tissues anterior to the orbital septum.
Sure, looking at blepharitis as well as an eyelid orbital condition that produces inflammation. Anterior bleph, posterior bleph. You know, anterior bleph, we think of Staphylococcus, Demodex. You know, lid hygiene, Azacite's a nice product. You know, we know an oculoplastic doc who we noticed that she was writing sometimes instead of Azacite, or if the patient couldn't get Azacite, she would give them erythromycin ointment. And it kind of makes sense. I mean, we haven't really seen it promoted at all in any of the literature like that, but it makes sense that it's the same class as a macrolide. So if there is some anti-inflammatory benefit to, let's say, Azacite, well, there might be some potential anti-inflammatory benefit to other products in the same class. So she's found it to be effective there, and we write it as well.
Right, and also, you know, we know that part of the inflammation is being caused by infection, so we have to address the infectious component as well. With presubtle, you'll typically use an oral antibiotic. With posterior blepharitis, part of the inflammation lies in that lipid lingering around the lid margin, and you have bacteria feeding off of it.
So just really quick, if we look at posterior bleph, we see lid hygiene, omega-3, artificial tears, oral antibiotics, lipid flow, and pulse light therapy. Anyone, you know, what are people recommending for lid hygiene regimens? Same? Sure. Sure. Yeah, I mean, I think, you know, we're beyond the baby shampoo only at this point. We can do better than that. Anyone recommending omega-3 supplements? Definitely, right? I think we're mostly doing that now. And it's funny because, you know, we think of well, why is omega-3 helpful? Well, there's supposed to be a ratio between some of these omegas. In this instance, we can say omega-3 and omega-6, which should be maybe 1-to-1, 1-to-2, something like that. For a lot of us, with this lovely diet that we have here in the West, it's somewhere around 17-to-1. So it really puts us in a pro-inflammatory state.
Yeah.
So, well, what do? You drastically change your diet and decrease your omega-6? I guess you could, but most people won't. So it's easier to add a supplement that increases the other one, the omega-3, and kind of brings the ratio more back into balance.
Right, and also, you know, in addition to the omega-3 supplementation acting as sort of an anti-inflammatory, we also remember that my meibomian gland production is being altered by this chronic inflammation.
Sure.
So what we're doing is we're trying to restore the meibomian back to their more natural, effective state.
Now, if you think of different conditions differently, like here we have blepharitis listed as an independent entity, right, as a standalone entity, and that's academically that's great. You define, you know, each condition its way. But in reality, I think we'd all agree. You see patient A, patient has really a hodgepodge of allergy, blepharitis, dry eye, and it might be weighted differently at different time points of the year, but they kind of have everything, a little bit of everything going on at the same time. And if you think of this pro-inflammatory state on the surface of the eye, well, that's when you will start getting decreased tear production, increased inflammatory output from the lacrimal glands, and inflammatory dry eye creeps in, and then it adds to this downward spiral. So when you have all this going on, if you don't address the inflammatory component at all, it's really unlikely that you're going to get the full resolution or the optimal resolution that this patient is capable of.
And I'm sure we've all seen in practice, we've had cases where it starts off with a mild posterior blepharitis that then eventually progresses to a chalazion now and again. And then in worst case, it'll advance to preceptal.
Sure.
You know, so we talked about the lids and the surface, and we're moving more towards the ocular surface now. So we'll talk about...
So just keep in mind, I know it says here bacterial conjunctivitis, corneal ulcers. You know, keep in mind, we're talking about not so much the infectious component of these conditions, we're talking about how to manage the inflammatory component. The infectious component, obviously antibiosis in whichever form is appropriate, whether it's topical or oral, will be the mainstay. But in terms of managing the inflammatory component, that's what we have a spotlight on here.
Yeah, because we all know that in addition to treating the infection, well, for one, it helps to have an idea of what type of an infection you're dealing with. But once you get the infection under control, you now have to deal with the inflammation that comes with it. Because you know, with inflammation to the corneal surface, you run the risk of corneal scarring.
Definitely.
And anyone here have any experience prescribing NSAIDs with their corneal ulcers or conjunctivitis? At what point are you all comfortable adding a steroid when you're treating the infection?
And I think I think for myself, the first thing I want to know, if this is an ulcer, is it a sterile ulcer that's really inflammatory? Then I want to go with a steroid early on, very early on, day number 1 maybe. Or is this an infectious ulcer, in which case I want to maybe go with the antibiotic heavily first, and once things are calmed down and the reepithelialization is more complete, then add a steroid. And for, you know, as far as non-steroidals, they're nice for pain. They can interfere with epithelial healing, so if reepithelialization is not complete, I would be a bit careful about adding a non-steroidal product at that point, until that point. Contact lens wearers, consider most infections are Pseudomonas and Staphylococcus. You know, with the exception, mainstay of treatment for bacterial conjunctivitis and corneal ulcers, you know, topical antibiotics, as we said, with the exception of gonorrhea and chlamydia, which then would require oral therapy. And, you know, while most of the country would say, duh, you know, here in New York, as we don't yet have full oral privileges, so, you know, we have to be aware of that.
And in addition to bacterial infections, you know, we have to worry about viral infections as well. Most cases of viral infections are adenoviral in nature. We're going to talk about our herpetic family in a little bit. And we've all seen the signs and symptoms. We have a follicular reaction, watery discharge. Sometimes you may have some tender lymph nodes.
So for those of us in this room, right, we're all local. We're seeing the same. We're fishing from the same population of patients. We're seeing the same patients. Has anyone seen a spike in viral conjunctivitis over the last year or two?
A few cases.
Yeah, we've seen. I don't know how many. I mean, I feel like it's 100 or more in the last couple of years. Yeah, it's very, very high. It's at certain time points of the year, it seems like it just spikes right up, and then it kind of tapers down, significantly, and then spikes up again. And we're talking about the incidence of viral conjunctivitis, how we're seeing a lot of overlap in the patients, right, between those of us sitting in this room, and I know we've seen a lot in the last couple of years. So we've seen a lot more.
Especially, just like how your upper respiratory and viral infections will have seasonal changes, we see them in the eyes also.
And we've seen those folks, they come in with they say, oh, I went to urgent care, they gave me these topical antibiotics, but they're not working, and you don't want to be that person yourself that they come to the next office and say, doc number one gave me this product and it's not working, So look for the conjunctival chemosis. They may complain their eyes are very itchy. It started in one eye and then quickly spread to the other eye. My whole house has it. That's another thing or another warning to give them, that it'll run through the house very quickly. Preauricular lymph node, go ahead and feel it. Pain is a funny thing. Some people will say ouch if you very quickly. Some you'll palpate it and feel something there, and they won't really say ouch. So
yeah, they'll just say it feels odd or unusual.
I feel a bump there or something. So definitely palpate for it.
Anyone here have experience using ganciclovir for adenoviral infections? Using topical NSAIDs? I know a lot of times, if I'm too concerned about the steroid prolonging the infection, the patient themselves and myself are more worried about signs and symptoms. I'll start off with an NSAID.
Sure. And I know for myself, these folks oftentimes, I'll let them know this will take somewhere between 2 to 4 weeks to clear up. You might have some subepithelial scarring, infiltrate scarring that can blur your vision a little bit. We might keep them on the steroid in maybe a prolonged way, a nice weak steroid, low dose, and take them off very slowly to help, clear some of that up, you could say.
And it's worth mentioning too, when you're using topical NSAID, it's worthwhile to ask patients about any autoimmune conditions because you are concerned about developing, worsening the keratitis.
Sure.
If they have Sjogren's, for example.
Yeah, anyone you have on a non-steroidal, watch their corneas for sure. We have seen folks with corneal erosion. We have seen folks who, had a corneal erosion for another reason, but they got a bottle of an NSAID from somebody else, and then the whole thing became a corneal erosion after that. So.
And now we talked about your adenoviral infections, but we can't leave out the family of herpetic infections. Interestingly, herpes simplex keratitis is the leading cause of corneal blindness in the U.S. And the hallmark sign we've seen in textbooks in the office oftentimes is the dendritic ulcer.
Now, can you get herpetic keratitis bilaterally? You won't usually see it, but you can get it. We saw a gentleman that had
I saw one case of it. Yeah. I know we're taught in school that it typically affects one side. We had a case where it was in both eyes.
Yeah. So if you think of, in 15 years for me, 5, 6 years for you, one case where somebody had it bilaterally. But so while it doesn't happen often, the fact that somebody comes in with this bilateral presentation doesn't automatically mean it cannot at all be herpetic because it's bilateral. It could be. Now, this was a gentleman who was able to fill in some of the blanks because he knew his history very well. He was able to say, yes, this happened to me before. Yes, it is. I know everyone thinks it's not, but yes, it is. So he was able to fill in some of the blanks.
Yeah, especially in cases where it's a viral conjunctivitis, it's bilateral, so you're suspecting adenoviral. And in cases where you're using a topical antibiotic that's not working, I've met a corneal specialist who would try trifluoride, and sometimes it will work, even with adenoviral infections.
Yeah. One thing, if you see, just a quick pearl, if you see a unilateral SPK with some degree of anterior uveitis or iritis, even if it's very mild, suspect there's a herpetic component until proven otherwise. And in those instances, I can think of instances where I did not give an antiviral early on, and it just kind of lingered, festered, or got worse. And now in other instances since then, I do give the antiviral early on, even if there's no classic dendrite, and it does help. It does clear up. So does that confirm the diagnosis? You know, maybe.
And then we know the virus lays latent in the trigeminal ganglia in the cases of when it affects the surface of the eye. So we do have to warn patients about recurrences. Now, the good thing is the infection does resolve on itself spontaneously within 3 weeks, but we now have to worry about the inflammation that affects the ocular surface. And we have to worry about corneal scarring. If they develop an iritis, we have to worry about the anterior chamber as well.
Sure. Topical ganciclovir versus topical trifluridine, is there really a difference as far as if you could give one, if you had the option to give either one to the patient, is there a difference, or are they kind of just equal all around? Right.
Yes, ganciclovir is less corneal toxic. Right, or use artificial tears, yes.
Right. So the idea is that yes, ganciclovir is supposed to be selective for the infected cells, virally infected cells only, and not damaging to those that are not infected. Right.
But at least with those of us practicing in New York, the hurdle is the cost for patients. I'm sure that's why a lot of us end up using trifluridine. Now, in addition to herpes simplex, we have to be concerned about herpes zoster, which is caused by the varicella virus. And sometimes we'll see the Hutchinson sign on the nose, which we'll suspect zoster. Now, more often than not, these patients will end up going to their primary care doctor before coming to you. And the primary care doctor will already start them on an oral regimen and just ask you to manage any ocular sequelae.
Yeah, just to they'll already be on treatment, and with a referral to you from the primary doc, they'll come in. Mainly, the primary doc wanting to know, is there ocular involvement? If there is, please help us out.
Because from a primary care standpoint, they're unable to manage any iritis, worst case optic neuritis, vitritis. And the treatment options are very similar. Oral antivirals, topical ganciclovir, not trifluridine in this case, will not be effective enough. If they have an iritis, you'll use a cycloplegic or a corticosteroid.
Ganciclovir, it's an interesting product. I've read about, I haven't used it for this, but I've read about for adenoviral infections that it can help shorten the duration and the severity of disease. I haven't used it for that purpose. I don't know if anyone here has, but I've read that studies have shown that it's helpful in that area too.
And the nice thing is too, you can mention to your patients who aren't aware that there is a vaccine for it, and it's recommended for people over 60, to prevent the risk of recurrences.
Great.
Any questions at all? No. To our online audience, if you have any questions, please post it in the chat. Now, moving away from infections affecting the ocular surface, we're going to come back to allergies again, which we mentioned earlier in the talk.
So allergic keratoconjunctivitis, type 1 hypersensitivity reaction, IgE-activated mast cells and basophils degranulate. So we think of that part of the graph up there, or the previous one of the previous slides, where there's the mast cell degranulation, releasing histamine and prostaglandins, leukotrienes into the intercellular space. And again, ketorolac was originally approved, the non-steroidal product ketorolac was originally approved for seasonal allergic conjunctivitis before postoperative inflammation.
I like to mention here, because of the fact that the histamine, the basophils activate the release of prostaglandins and leukotrienes, this is where NSAIDs can benefit patients who suffer from chronic allergies, in addition to using it with topical antihistamine.
So if you think of one of the previous slides where we had the inflammatory cascade, and up on top we had where the histamine is being released, and down in the lower corner we had leukotrienes and where the non-steroidals are active. And then one thing that we're seeing here, prostaglandins, leukotrienes, and histamine. So sometimes one product might not be enough. And so when you're writing an allergy drop, it's nice to try and be aware of, we're not going to do the full presentation on this topic today, but we will do it another day, on the receptor profile affinity of the allergy product. Some products like beclotastine, it's all H1. Great for itching, doesn't really do anything else. other like H1, H2, H4, nicotinic receptors, muscarinic receptors could mediate in some way, worsen or not, the patient's dry eye, pre-existing dry eye. So if your patient's not, if you can think of what's happening on the surface of the eye with this patient, what are the receptors involved, what product, allergy product can I choose that helps to kind of blanket most of these, instead of having to give them multiple meds and multiple classes. So sometimes it can make a difference which product to choose in this space.
And the nice thing from the standpoint as an eye care provider, with topical medication, we have very little systemic absorption. All the topical antihistamines, they have a very, very strong COX-2 profile, a very, very weak COX-1. Like I mentioned before, in the COX-1 pathway, other physicians are concerned about their blood chemistry and their digestive system. Less of an issue for us.
Sure. Is anyone, and just curious, you know, if you, those of you remotely, just think to yourselves, but for those of us in this room, is anyone going through that thought process before they write an allergy drop, or are you just kind of giving whatever's covered? Giving whatever's covered, right? But you might, and you'll see, and you've seen, I'm sure, different patients, product A, I love it. Next patient, product A, you know, next patient, yeah, I don't know. So I use it, sometimes I do, sometimes I don't. And, you know, also the instructions we give them are important. You know, if you think of your allergy drops, how did they get approved? Well, to get approved, they have to go through an FDA study or trial called the Conjunctival Allergen Challenge, right? The way that most patients use allergy drops, and it's partly our fault for not giving them better instructions, the way most of them use them is wrong. When my eyes itch, I put the drop. I don't use them otherwise. My eyes itch, I put the drops. But that's not how the drops work. They're not designed to clean up all that mess once this whole cascade has been triggered. What they're designed to do is block it from getting started. So what's the Conjunctival Allergen Challenge? Well, you apply the drop, afterwards introduce some allergen to the surface of the eye, wait a few minutes, and then you ask the patient to subjectively rate their itching score, right? So it's designed to block the response from getting started. And if it was effective in blocking these responses from getting started, it was able to get approved and be allowed to be commercially available in this class. Most of us are not telling patients that. Listen, you have allergy, put the drop each day until we tell you not to. Put the drop each day for the season. Don't wait until you're itching, because by then it's not going to clean everything up and you're going to come back and tell me the drop doesn't work. Or worse, they might think you misdiagnosed them, gave them the wrong choice of medicine, which you might have diagnosed them very well, given them great medicine, just inadequate instructions. You lose the patient. And we know, and I'm sure some of you know, patients will come in, they have a Ziploc full of drops, and you can see on the packaging who prescribed what. You might know some of these other docs, nothing wrong with them, great clinicians in their own right, just didn't give a good explanation. Good diagnosis, good product, inadequate explanation, lost the patient.
And just like in cases where an acute problem becomes more of a chronic problem, this nicely illustrates how a mild allergic conjunctivitis can progress to a more severe form.
Sure. So when you think of, let's say, something like ocular surface inflammation and dry eye, that's probably the most popular topic around ocular surface inflammation. You know, when you think of that, does it really make a difference? What happened first? Was it an inflamed eye that became dry, or was it a dry eye that became inflamed? You know, here's the situation where you're seeing from something that's not technically dry eye, inflammatory, you know, pro-inflammatory chemicals being released. And if we don't address that component, well, there can be ocular surface inflammation. And we know once the T cells show up to the surface of the eye, they live out their life cycle, 3 to 4 months that they're there, and they can remain active. And if we don't address that component for at least that time period, well, you can't set the patient up for chronic, for midterm or chronic ocular surface inflammation and the dryness and sequelae that go along with it.
Yeah, and we see how chronic itching, posterior blepharitis, allergies will progress to having ocular surface issues, which leads to chronic dry eye. So everything is tied together. And it helps to explain that to patients so they understand why they need to take their allergy medication regularly throughout the season if it's a seasonal allergy, or if they have to take it chronically every day. This helps stress why it's important.
Sure. Just before we go on, any thoughts about any of that? Did it make sense? It might be a little bit different than how you're used to thinking about allergy drops and tie in between allergy and inflammation and dryness and other complaints, chronic complaints the patient might have.
Okay.
If you disagree with anything, jump in. Yeah. Everyone here is knowledgeable. So.
And so we're going to just quickly summarize the different treatment options. Why are cool compresses effective? Because they induce vasoconstriction, so you're helping cut off the supply of all those pro-inflammatory mediators.
To that point, sometimes I'll tell patients, because we don't want our patients using vasoconstrictor products over the counter, right? Because all those products, you know, if they're packaged a bit trickily to start with. Some instructions are on the box, some instructions are on the bottle. You have to peel up the label to see the other half. But what does everybody do? They go home, open the box in the garbage, take the bottle. Later on, when they read the instructions, it says full instructions, see box. Box is gone, recycling already. So if we don't want our patients using those things, sometimes what I'll do is I'll tell them keep the tears in the fridge. That way it's cool. It'll give them a tiny bit of vasoconstriction with no secondary effects, no negatives.
You know, we mentioned, you know, antihistamine drops, mast cell stabilizers. NSAIDs, again, can potentially work nicely using in combination with other treatments. We will use corticosteroids for really severe allergic responses, and that's again because of the chronicity of the allergy. And we mentioned before how it blocks the formation of arachidonic acid, which again will knock out all the pro-inflammatory mediators. And also allergen avoidance. Sure.
So, you know, we were talking a little bit about how we made a reference to something that 6 is greater than 1 and all this. So here you see, here's the mast cell. You have degranulation of the mast cell, you have the release of histamine, but you have other things happening too. You have on the far left there, histamine, leukotrienes, chemokines, tryptase. Yeah, thanks. Chemokines, tryptase. You have cytokines. You know, cytokines which then summon and activate T cells. You know, the helper T cells calling the quote-unquote killer T cells, which then show up and live out their life cycle on the surface of the eye. If there is no pathogen or invader for them to attack, well, they'll end up beating up host tissue, damaging the ocular surface, causing more inflammation, and then down and down the cycle goes. But you see here, antihistamine, you have one area covered, but there's more happening. So that's why for some patients, you know, a steroid or a non-steroidal can be good, can be helpful as well, or an antihistamine alone won't be enough. You know, we did ask the question before, if the steroid acts up here, higher up the chain, why do we need a non-steroidal at all around surgery or at all? You know, one way to think of it is right there where you have that arachidonic acid and phospholipase A. Think of that like an open window, okay? And you have angry bees flying through that window, right? You have angry bees flying through that window. Well, you give the steroid, you're catching a process that's already in motion. The window's been open, the bees have come in, right? You give the steroid, you close the window, but what do you do with the bees that are already in? Well, that's where your non-steroidal helps out. That's where your non-steroidal helps to mediate some of those pro-inflammatory chemicals that have already been produced and are already causing an activation of further down the pathway.
And we know with T cells, you know, they linger around for anywhere from 80 to 90 days. So patients with those really, really severe allergies, they may need long-term treatment to get them from severe to moderate back to mild again. And again, that's to clean up all those nasty bees.
So with that in mind, you know, sometimes think about if you're going to start a patient on a steroid, maybe early on to really alleviate their symptoms and take care of the bees that are already in, maybe early on you could use both. It might make sense in certain situations to have a steroid and a non-steroidal early on, and then maybe stop the non-steroidal, and then you'll see what to do with the steroid as appropriate.
And then we suggested earlier that various types of infections, severe allergies, a lot of times we'll see this patient then develop subsequent dry down the line, and we wonder why. And a lot of it's because this chronic inflammation begins to alter the tear film. And
Sure.
The old school way of thinking was the tear film had these 3 distinct layers. You know, you have your lipid layer, aqueous layer, and mucin. But now we start to think of it more as a soup. And in the soup, you have a lot of anti-inflammatory and pro-inflammatory mediators that sort of form a balance to maintain the surface of the eye. And that we know with chronic inflammation, we're shifting that balance more towards a pro-inflammatory state.
And you might think of an instance where, let's say you have somebody who had dry eye, and you said, oh, this patient could use plugs, right? That makes sense for dry eye. And you put the plugs, and the patient comes back with a more red, watery eye, saying take these things out. Why? Because you basically plug the pro-inflammatory soup on the surface of the eye without addressing the inflammatory component that was already active, and then plugging them after.
Right, this is why we tend to use punctal plugs down the line after we have them on a regimen of anti-inflammatories. And now this is a more modern view of how we attack dry eye. We look at it as a form of chronic inflammation. We see how change into meibomian glands can happen with chronic inflammation. We see how the surface of the eye can alter the surface of the epithelium of the conjunctiva cornea, and there you're disrupting your mucin production and mucin layer. We'll talk a little bit later how with chronic inflammation we have a reduction output from the lacrimal gland, and what the lacrimal gland does produce has a higher concentration of pro-inflammatory mediators.
It gets
all these things sort
infiltrated
of,
by inflammatory cells, which will then come out. Sure.
yeah. So all these things sort of feed into the disrupting the surface of the eye, which leads to chronic dry eye.
So risk factors for chronic dry eye, certainly anything that will predispose the surface of the eye to inflammation, there's a risk factor for chronic dry eye there. Aging, gender, dry environment, hormonal changes, medications, contact lens wear, blepharitis, prior history of LASIK, and any autoimmune disease. Any autoimmune disease patient is definitely a chronic dry eye patient, or at risk of being a chronic dry eye patient. Nice healthy ocular surface, you end up going from there to having an abnormal or decreased tear composition or an abnormal tear composition, reduced tear clearance, increased tear osmolarity. So then, osmolarity, maybe some of us haven't thought of that term since we took chemistry, but it's definitely relevant in dry eye as a ratio of solute to solvent. And if that goes too high, then the surface of the eye is a bit too dry, and you have inadequate lubrication. Ocular irritation, increased cytokines, and then down the inflammatory cascade we go. And it becomes a cycle where right around here, where you have active inflammation, comes back up here to a further, more abnormal or further decrease in tear production, and then it keeps spiraling downwards. Does it make a big difference where you interrupt the pathway? I mean, you're seeing something in motion. Academically, we can pick it apart, but clinically, you catch it where it is, and you get started. And that's why a lot of folks who we say, oh, you have a dry eye, but they'll say, but my eyes are watery. The patient's saying my eyes are watery, and you're saying, but you have a dry eye. Already their perception can be you're misunderstanding my problem, because I'm telling you my eye's watery, you're telling me it's dry, and you're just giving me tears, you're adding lubrication to something that's already very wet, that doesn't always make sense to the patient.
Now, I know there's a lot going on this slide, but again, it's just to reiterate how dry eye and inflammation form a vicious cycle. And the nice analogy is, which came first, the chicken or the egg. And we'll talk a little bit later why it doesn't really matter. You can attack it from both directions. You treat the inflammation and also you treat the dry eye as well.
It's a little cool, but if you break the eggs, no more chickens, and if you kill the chickens, no more eggs, right?
Yeah,
So
we talked about how allergies, contact lens wear, and the environment can change the tear film chemistry. This increases osmolarity, you have cellular damage. We talked about how when cells get damaged, they release pro-inflammatory mediators, and that recruits our immune system, which then leads to more chronic inflammation.
So, if we think of the initial three things we talked about, infection, surgery, or injury, right? Having had a history of these things. Once patients are healed, we like to tell them that, okay, you're good, but for your tear film to balance itself out and have a more normal composition, 3 to 4 months. 3 to 4 months for whatever pro-inflammatory activity is in there for those T cells to basically die off and for you to be left in a nice balanced state. So we try and follow them up pretty vigilantly during that first 3 to 4 months so they don't get set on this chronic dry eye pathway.
Yeah. And we all know in clinical practice that any of these external factors can trigger the cycle of inflammatory dry eye at any point in the cycle.
And I think any of us who are in a joint ODMD setting or doing perioperative management, the most common things people come back complaining about after cataract surgery when they get off their post-op drops, but now my vision fluctuates when I blink. Yeah, I mean, aside from floaters, right, that they didn't know they had. But they'll complain about symptoms around dry eye. So definitely this is why. So definitely be a bit proactive about that.
Or when you have your young contact lens wearers, that will give you the symptoms of very, very mild dry eye. Although when you look at the surface eye, everything looks fine, they're complaining about mild foreign body sensation, occasional burning, they end up throwing out their contacts earlier than they'd like to.
Well, those are the patients who, because we think of it, we have two pillars of practice, right? We have a medical pillar, we have an optical pillar. We're very lucky. And they're not mutually exclusive. But these patients who you'll give contact lens trials without having, let's say, addressed what might have been a mild dry eye on the front end of giving them trials, they'll wear the trials, have a good experience for that 10, 15 minutes in the office, and then during their trial period, start noticing they have a bit of a dry eye, and then they'll say, oh, this isn't for me, contacts gone, if I'm not wearing the contacts, if I failed with samples, I'm not buying contacts, if I'm not gonna buy the contacts, no reason to come back to the doc, you'll see them 2 years later when they get an eyeglass voucher. So you just shot both pillars of the practice in the foot by not addressing this on the front end.
And again, to summarize our dry options, a lot of us will initially start off with artificial tears, ointments, gels, preservative-free if we're worried about preservatives and they're using it very often throughout the day. We also mentioned why this may work in very, very mild cases, but once you suspect that there's an inflammatory component, it's not going to work 100%.
And we did write there topical cyclosporine. Lifitegrast should be mentioned there as well. You know, it's maybe new for mainstream eye care, but it has been behind the scenes for a couple of years, and we saw in which part of the inflammatory cascade it acts. Okay, so here's one that I think we all see sometimes. Episcleritis versus scleritis. Anyone here seen a real scleritis in the office? We've seen a couple. You know, I think after 15, 16 years seeing high volume of patients 6, 7 days a week, you should have seen a couple at least. Episcleritis we see more often. I think that everyone's seen an episcleritis, probably. And sometimes something that you might not recognize as an episcleritis is actually an episcleritis. So, you know, benign self-limiting inflammatory process versus a painful, potentially blinding inflammatory disease. Episcleritis is much more common, minimal pain. You know, the patient will complain that they're uncomfortable, but it's not really a deep, boring pain. Scleritis commonly has an underlying autoimmune disease and requires co-management. Rheumatology, if you see a scleritis, good thing to get a rheumatologist involved, primary doc involved. Topical, you know, treatment, topical corticosteroids, oral NSAIDs, and treatment of underlying disease. Scleritis, some literature you might read will say there's no value at all to topical steroids. You have to go straight to oral steroids. We have found with the few cases that we've seen that good topical steroids were effective. Difluprednate's a good one, nice and strong. When you're tapering them off, you know, just like you don't want to go from a very high frequency dose of a steroid to 0, as they can have some rebound inflammation. Sometimes with some of these things, you want to have a nice slow taper, and you don't want to go from a very strong product to 0. So you can taper down. Now, I was talking to another OD that I know. His name is Kevin Chan. His main area of expertise is myopia control, but you know he's knowledgeable in this area too. So we were talking about it, and he was saying sometimes what he does, he'll taper down from a stronger steroid like a difluprednate, Durezol, down to a pred, down to a loteprednol as he's lowering the dose. So that gives him room for a long, safer taper with less chance of a rebound inflammation. So that's a nice little pill to keep in mind.
Also, one of our online doctors asked, you know, does untreated dry eye lead to ocular inflammation that needs treatment with steroids and NSAIDs? And yes, as we mentioned before, when the dry eye becomes chronic, like we mentioned in the cycle, it does lead to inflammation, which requires the usage of a steroid.
So how does that happen? If we see somebody who, let's say, has a chronic dry eye, or when they sleep, they have a bit of, let's say, lag ophthalmos, you'll see an SPK in that area, right? A punctate keratitis, or if the cornea is a little too dry for too long, they'll develop a bit of a keratitis. So, you know, SPK, keratitis, itis, there's already an inflammatory component there. From that point, you start having these pro-inflammatory pathways that are active, and then you start going down the slippery slope of decreased lacrimal tear output with increased inflammatory output, and down you go.
Was that it for the question?
Now moving back over to the conjunctiva, we see changes to the conjunctiva as a result of chronic inflammation. In the case of pterygiums, pingueculas, that's a situation where we have UV exposure and mechanical rubbing that leads to remodeling of the conjunctival epithelium. And we know that pterygium pingueculus, it's basically a vascular lesion. The question is, when does a pterygium pinguecula require treatment versus ignoring or monitoring? Do you ever ignore a pterygium or pinguecula? As in, you don't address it if patients don't complain about it.
I don't. You know, I think it's easy to do that. I think it's easy to slip into this comfort zone or this trap of where if they're not actively complaining, and then I'm just going to kind of not really address it or not really get into it because there's no complaint around it. But there's two sides. There's signs and symptoms. Symptoms are what they're complaining about. Signs is what you see. So if you see somebody with a pterygium or a pinguecula, you know that this thing is, let's say, elevated like a little island on the surface of the eye. And just like an island, well, it's wet, you know, around it, but on top tends to get more dry, just like the surface of an island, right? More exposure to the wind, more exposure to the sunlight, more exposure to irritants in the air. And then with that dryness, from there you can get inflammation that spreads, the inflammatory chemicals mixing with the tear film, going everywhere, and then back on the same pathway they go.
And just like dry eye, allergies can progress from a mild acute condition to a severe chronic condition. Think about it, pingueculas are basically the predisposition for pterygium. So it helps to explain to patients that, look, this can progress. Mind you, it may take years, but it can still happen if it's ignored. It can progress to a pterygium.
Sure. When to treat topically? I mean, so what, just, you know, what are some of us doing for, I think we're doing UV protection, we're doing tears. Anyone giving steroids for pingueculitis or inflamed pterygium? I think so. I think we all do as needed.
Also,
I'm sorry, as a separate observation, right, I know that the immunomodulative products for dry eye, like cyclosporine, lifitegrast, you know, some of these patients, like we've said, if they have a condition that predisposes them to ocular inflammation, they're kind of set up to get an inflammatory dry eye. And to treat that component, we have given some of these immunomodulative products, like cyclosporine or lifitegrast, and have noticed as well, as a separate observation, that the condition like the pterygium or the pinguecula would be less chronically inflamed as well, without having to always resort to a steroid or leave them in an open-ended way on a soft steroid for months at a time.
Yeah. And also, you know, it helps to, you know, educate patients about reducing their UV exposure, avoid mechanically rubbing the eyes. If they have outdoor allergies too, they have to address that.
So these are patients for whom, let's say, if they have an allergy, antihistamine alone might not be enough, because they have more stuff going on the surface of the eye.
And again, to summarize the treatment options, you're going to recommend UV protective eyewear to your patients, artificial tears if you notice a dry eye component to as well. For our acute inflamed states, you're going to use corticosteroid.
Sure.
In cases where it's becoming visually significant, you can suggest a surgical excision.
And there is a significant chance of recurrence as well. You know, pterygium surgery is not always just cut and dry. Sometimes they get a recurrence, sometimes they get scarring that can leave them a little esotropic or diplopic on opposite gaze, you know, to the side where they had the surgery. They might not be able to abduct all the way after that. Sometimes they get a granulomatous scar that has to be removed after that. If it was really, really big, sometimes they can even come back saying, hey, the scar is attached to the lid, and now their eyes are a little bit closed, and they can get set up for a second surgery. You know, so even if they have surgery, you have to, all of these things that we talked about for the patient who has the pterygium, all apply for the person who just had one removed.
And if you're managing them post-operatively, you have to be concerned about patients who have any autoimmune pathology. You have to worry about corneal melts or scleral melts.
Definitely.
Patients with collagen vascular disease.
You want to be careful with non-steroidal for those folks too. Anybody with collagen vascular disease, so more chance of epithelial, corneal epithelial issues. So looking at anterior chamber inflammation, now moving inside the eye.
We're just going to backtrack one moment, sorry. One of our doctors online mentioned anti-reflation lens Frenton. Anyone here familiar with that? Anyone online that's reviewing, if you have any thoughts about anti-reflation lens Frenton, throw it out there for us, please. Sorry.
Okay. So now moving from lid inflammation inside the eye, anterior uveitis, pain, photophobia, perilingual redness, that ciliary flush that is kind of characteristic of an anterior uveitis, AC reaction, cells flare originating from the iris vasculature leaking into the anterior chamber due to increased vasodilation and permeation. When we think of vasodilation, just to back up one step to the surface of the eye, one thing that I like to do, I like to stain most folks with fluorescein, because sometimes if you think of vasodilation, you have the leaky vasoendothelium, you have the migration of fluid, and with that fluid, you have inflammatory cells, right, that are kind of setting this process in motion as well. It's sometimes hard at the slit lamp to appreciate a very subtle conjunctival chemosis, but if the eye is stained just with a little bit of fluorescein, it will jump right out at you. Even the slightest bit of chemosis will just jump out at you. So even though we're not set up, most of us are not set up to do tear film assays in the office looking for pro-inflammatory markers, once you see that little bit of conjunctival chemosis, you have an idea, okay, there's a leaky vasoendothelium. With that fluid that's migrating, there are also inflammatory cells migrating, and there is an inflammatory component here that should possibly be addressed. Treatment for uveitis, as we were saying, topical corticosteroids, cycloplegia, chronic, bilateral, or recurrent episodes, do more blood work. We'll talk a little bit about the blood work. Primary doc is nice to get involved. Rheumatology is nice to get involved. Things that are not either healing in the right time frame, or they keep coming back, or they're just not responding the way you would expect to normal treatment. Don't hug it too closely. Definitely get someone else involved. Studies comparing nonsteroidals to corticosteroids and placebo don't really support nonsteroidal usage as an alternative to a steroid. But for someone who seems to have, long-term uveitis or recurrent uveitis with a risk of CME, there may be an off-label role for nonsteroidal in that patient.
Yeah. And also remember too, when you are seeing cells in the anterior chamber, it's coming from the iris vasculature, and it's leaking out of the vasculature because of this increased vasopermeability because of prostaglandins. So this is how corticosteroids help reduce these cells in the anterior chamber. When you see vitritis, you're seeing cells spilling over into the vitreous, and they're coming from the ciliary body, and also retinal vasculature. We're going to talk more about that later too, when we talk about posterior uveitis.
As far as blood work goes, CBC, ESR, ACE, HLA typing, ANA, rheumatoid factor, VDRL, Lyme, CXR, these are the basics. Posterior segment inflammation. We think of posterior uveitis. We can think of panuveitis. We can think of pseudophakic CME, optic neuritis, chorioretinitis, vitritis. Anyone using nonsteroidals for CME? Okay. I think if you send a patient to a retinal doctor for CME, you will find in many instances they'll come back with a nonsteroidal. They might come back with a steroid and a nonsteroidal twice a day, something like that.
Yeah, usually conjunctively.
With intent to follow up in a month, and looking for any improvement.
And the belief in how NSAIDs target CME is that it affects the vasopermeability of the blood-retinal barrier, helping reduce the retinal edema.
Can you repeat that one more time?
The belief in how NSAIDs help target chronic CME or acute CME is that it impacts the blood-retinal barrier at the level of the retinal vasculature. So we have these inflammatory mediators leaking out of the retinal vasculature. They're not coming from the vitreous. Remember that. They're coming from the retinal vasculature.
So now that you know how it works, it might make sense to try it sometimes. And any of these drops that penetrate transcorneally and have a role inside the eye, you want to instruct the patient to use them correctly. Remember, most people's reference point for how to instill eye drops comes from vasoconstrictors or over-the-counter lubricants, right? And what do? Drop, drop, blink, blink, blink a few times. Some runs down here to one ear, some runs out of the eye to the other ear, and repeat, right? Do it a couple times a day. This is different, whether it's for IOP meds that penetrate transcorneally, or you're treating for uveitis, or you're trying to give something that might potentially help with CME. You want to have them put one drop as they're supposed to in each eye, eyes closed, tuck their chin. That way, the medication will likely stay where it's supposed to. You won't see it running out so much. You get the benefit of the full dose. Tuck their chin. The positioning will help it collect as much as possible near the cornea, since they penetrate transcorneally. And then, in some studies, to get the maximum effect, they've had them rub the front of the eye very gently to disrupt the epithelium a little bit, allowing for maximal transcorneal penetration. So sometimes if you're giving a patient an eye drop that you intend to have, that the effect is intended to be intraocular, whether it's for IOP or inflammation, and you're not seeing the right effect, or you want to definitely see the right effect, try and educate them on how to use it. And you'll find that if most people will say, oh, I don't do it that way. Yeah, no surprise. That's why their pressure's unchanged when they come back, after starting them on IOP meds.
Yeah, and a lot of times you may see macular edema in cases of a retinal vein occlusion. If it's clinically significant macular edema in the case of diabetes, some retinal docs will use NSAIDs off-label to treat it concurrently with, if they're using anti-VEGF therapy or intravitreal steroid. That's also how intravitreal steroids work too. The steroid targets the same barrier. We're going to talk a little bit more about the other types of posterior uveitis. With vitritis, you'll classically see cells in the vitreous. In your non-infectious cases, you're concerned about autoimmune pathology, rheumatologic cases. In the case of infection, you'll do your basic blood work. Some of the most common infections are going to be Lyme, syphilis, herpetic infection. If your patient is immunosuppressed, you may think of CMV. Parasitic infections such as toxoplasmosis, toxocara, or fungal infections. Again, if the patient is on immunosuppressants. Why is vitritis a concern? It is because it can become vision threatening if it progresses to macular edema. Or if you have these fibrobascular lesions on the retina, you may worry about retinal detachments, neovascularization, retinal ischemia, or if these vitritis creates a vitreous opacity, obstructing the patient's vision.
Always be vigilant with neovascularization, especially anybody who's had previous retinal vascular occlusion. Really take a look for it, and look for neovascularization of the iris as well. Definitely look for that, because sometimes it'll happen far in the future, sometimes not at all, sometimes it'll happen pretty quickly, and they'll come back with a hard-to-treat neovascular glaucoma. Treatment, typically intravitreal or oral steroids and antimicrobial. Topical steroids can help well with anterior segment inflammation, but aren't really the dominant mode of treatment for posterior segment inflammation.
And we'll talk a little bit about chororetinitis and choroiditis a little bit later. But as far as strictly from a retinitis standpoint, we've all seen cases of retinitis pigmentosa. How many of us here will recommend a regimen of oral vitamin A to help slow progression? Do you guys recommend that to your patients at all?
I've had patients come back and say that they were recommended that, elsewhere. It might not have come necessarily from us, but I've seen patients on it. But to my understanding, there's not a clear consensus on the dosing and
Well, interestingly, a study was done by the National Eye Institute a few years back in conjunction with the NIH, and they found that using oral vitamin A can help slow the progression. But it was a small-scale study. It was only maybe about 600 patients, so the jury's still out there. You also have to be worried about the impact of high doses of vitamin A on the liver.
Actually, I'm remembering,
especially in your younger patients.
I'm actually remembering now some of the patients who came back and said they were on vitamin A. They had said they were part of studies in some of the hospitals, yeah.
Also, in your infectious cases of strictly retinitis, you're going to be thinking of CMV in cases where patients are immunocompromised.
Toxo, right? Toxo is another one. That's worldwide. That's a leading cause of blindness is toxo. If anyone here has seen toxoplasmosis, if you've really seen thousands of people in New York over your career and you haven't seen any toxo, there's a chance you might have missed it. So definitely take a good look. Just because it's not active and there's no active vitritis, and iritis now, doesn't mean that they don't have a lesion there that's just sitting waiting to activate at some point. Okay, optic neuritis. So what is optic neuritis? Demyelinating inflammation. Common non-infectious etiologies include multiple sclerosis, lupus, and sarcoid. The optic neuritis treatment trial found that treatment of IV steroids really did not alter visual outcome, but did speed up recovery. Oral steroids even increased the risk of recurrence in this study.
So what the studies found is whether you treat the optic neuritis or not, patients will end up with the same visual outcome. And that if they are going to be treated, they're better off with an IV steroid. But with oral steroids alone, there's a greater risk of it coming back.
If you think a patient really has optic neuritis, does it make any sense to start them on a topical steroid and wait and see how they do?
I don't think so. I think it's a benefit to the patient to send them out.
Right, you're just delaying treatment at that point. So,
I mean, they'll need imaging done to rule out multiple sclerosis. Blood work will reveal if they have any signs of lupus or sarcoid. This is going to fall into the realm of neuroophthalmology and rheumatology at this point. But now, if there is any spillover into the anterior chamber, we can still address that with topical steroids.
right. But these are patients who,
As in the case if they have, like, for example, if they have Lyme, zoster.
but these are folks who, once you refer them, they might end up within a short time admitted to the hospital while they're being treated with IV steroids. Okay, so choroiditis, chorioretinitis, moving further back. Oftentimes there's an infectious etiology, as we said, toxo, CMV, syphilis, TB, ocular histoplasmosis. How about trauma? If you have significant trauma, can you get ocular inflammation as well, anterior seg, posterior seg?
Yeah, if it's severe enough, it can spill over into the posterior chamber.
So again, looking at these etiologies here, these are patients where while you might be able to manage some of the ocular inflammatory component in the office, they need a more extensive workup than we're equipped to provide in the office. Again, you want to get the primary doctor involved. If you know the list of blood work to have them, do, you can send that to the primary doc. If not, but you're suspicious of an infectious systemic condition, even if you don't remember this list, or as this list I'm sure will grow over time, if you're not sure of all the conditions to write down, then just send a note to the primary doc, that there's a chorioretinitis, you suspect that they may have some underlying systemic infectious condition that has yet to be determined, and let the primary doc take it from there, while you follow up and manage the ocular component.
In the last lecture today, we're going to be talking more in depth about posterior uveitis. The take-home message here is that, recognize that there's an inflammatory component here that should be addressed, and if it's not, it can progress to macular edema, which can cause vision loss.
Right.
So we're approaching the end of this talk. The message here is that, corticosteroids, topical NSAIDs are powerful tools that we have, but we have to use them judiciously to, control the inflammation that we encounter with cases of infection, autoimmune pathology, allergies, because all these things can pose a threat to a patient's vision.
Sure, and understanding how inflammation arises lets us make better choices or more appropriate choices in terms of the treatment options that we have, and how it can affect different segments of the eye, and sometimes we need to co-manage with other specialties.
If you guys have any questions, you can throw it out there. I'm going to, broadcast any questions to you guys that we have from our online viewers.
And we're also going to take probably 5 minutes and switch to the next one. So if you guys want to take a break, take a breather, stretch your legs, feel free.
It's up the front. You see the sun on the right side where it says ladies?
anti-inflation lens rental review.
That was not. All right, everyone who's viewing online, if you have any questions for us, myself, Dr. Singh, or Dr. Kabiri, please message us in the chat and we can address it. We're going to resume the next lecture in about 10 to 15 minutes.
To allow adequate time for questions.
Yes.
Well, listen, if we had all these folks in front of us, those questions would come in. It'll have half an hour, answering questions and all that. So,
You guys were doing this from keeping it more clinically run. I've gone to a couple of other CEs where
it's just not a textbook.
exactly, yeah, and I appreciate the fact that you guys, it seems like you guys are actively trying to make it clinical, and I appreciate
Relevance, yeah.
that. And I wanted to just say
Thank you.
okay.
Okay, one of our viewers online asked, how often do we, when we're treating patients with dry eye, how often do we start off with an immunomodulator or a steroid, or do we always start off with tears?
There are very few absolutes, alwayses and nevers, very, very few absolutes like that. And this would not be, one of them. So it depends on the patient presentation. If it appears that there is an active inflammatory component, then yes, they're going to get either an immunosuppressive or an immunomodulative product, or perhaps both at the onset. If it appears that there is no inflammatory component, for example, somebody who says, I just got off the plane this morning and their eyes are a little bit dry because of that, that's not a chronic situation at this point. They might just start off well with a tear, and then we'll see how they do, but if it turns out that they're flying a couple of times a week, and then this is the state a couple of times a week, sure, then they can get set on that pathway. They might need a bit more of a product than just a tear.
Another viewer asked, when treating dry eye, how often do we incorporate using a nutraceutical, such as omega-3?
That's a great question, and I think that recommendation, if there's an inflammatory component, because that's really what that's about, is it's not that it's actively lubricating the surface of the eye as much as it's helping to restore the ratio of omega-3 and omega-6 in the body that will kind of offset this pro-inflammatory state and help mediate the inflammation in the body, including on the surface of the eye. So that's case by case. In terms of how often, well, if there is an active inflammatory component or presumed inflammatory component, then very often. If it's that person who just got off the plane and their eyes are a bit dry because of that, then I don't think they need to go running to the health food store for omega-3s for that purpose.
Right, so in the long term, it works great from an ocular health and systemic health standpoint, not so much to treat any acute issue that they might be having. So it's important that you recommend to patients, if they're going to be on nutraceuticals, it's going to be a lifelong routine. Very good question. These are very good questions, guys. Please throw out any more that you have. You can send it to us in the Q&A.
Yeah, that's right.
Another viewer asks, when we're treating allergic conjunctivitis, do we ever recommend oral antihistamines?
Sure.
I think you can if they have an allergic sinusitis component to it as well. But I would also want to involve their primary care doctor if you're suspecting any sinus issues that could be lingering with it. And it's also worthwhile mentioning that the oral antihistamines can also cause dry eye as well.
Yeah, I think one thing to keep in mind when it comes to dry eyes, allergies, things like that, we're not the only ones that have our hand in this pot. There's the optometrist, the ophthalmologist, the primary care physician. There's the allergist, if they have some underlying autoimmune disease, the rheumatologist is in there, maybe trying to manage the surface of the eye a little bit as well. The pharmacist for the over-the-counter products has their hand in there, plus all the marketing that's already in just floating around on TV and whatever the patient reads. So there's a lot of people with their hands in the pot here. So it's nice to, if you think there might be some other component like a sinusitis or something, to involve another physician. We're just answering a few. This one still. Did you ever see the show on And we have a soon-to-be fourth-year student sitting in the back here. So feel free to, I don't know, pick brains, whatever, meet and greet. This young man might be doing. He's done something. He's looking at herpetic, active herpetic. Sorry, active herpetic, active ocular infection of any kind, as an immunomodulator. And that's really it. I mean, of course, if they have any known hypersensitivity to any of the ingredients in the formulation, blah, 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 but that's really it.
So if someone's on it, so they have to be told if your eye gets red or anything, have to stop using it?
Well, so you're saying someone who's new, who's starting it new, right? Who's starting it new. So what I would do with any product that I'm going to start them on, I want to bring them back in the first 1 month to address exactly that point. Anything, I want to tell them on day number 1, what are the normal adverse effects? So that's something you should read the package insert. What are the normal adverse effects in case of restasis? Slight stinging upon installation, transient blurring of vision. That's pretty much it. You know? That's pretty much it. Those are the main two. I want to let them know those things. If you notice anything other than that, come back sooner or call. You know, come back sooner. But as long as if you notice those things, it's normal, it's not hurting you, and we'll see you in 2 weeks. And in 2 weeks, I'm not looking to see if the dry eye improved. I'm really seeing how well they tolerate the treatment. Is the treatment affordable to them? Is there anything they don't like about it? So I have a chance to address those separately. And otherwise, what will happen if you just say, well, I have an idea of how this is going to work. I envision this person as a good candidate for this product. I'll see them in 4 months to see how the dry eye is doing, which makes sense from a dry eye standpoint, right? But along that road, they start noticing the normal or abnormal effects. Doc's not interested in my case. If she thought these things could happen, she should have seen me sooner. I'm going to go get a second opinion. You know, a friend or family will put down their head, come see my guy instead of the other way around. Them convincing their friend or family to come to you, you lose. And I know because we see a lot of folks who come in with, like I said, with a giant Ziploc of meds. They've been to everybody in the area. You know, but we realize sometimes that, okay, communication is a factor here that constitutes practice as a patient. So we'll shore that up a bit and retain them. But that's it. As far as herpetic,
What you're worried about, so if they found gets the herpetic infection when you're not seeing them 2 months later, how are they supposed to know not to use it?
well,
Or you tell them.
so whoever's
managing
managing their herpetic keratitis, right, should be saying, what else are you using right now? Well, they just sit there by themselves and get a herpetic keratitis.
I don't know, if that's a concern or not.
Really.
Well, you can stress to them, you know, if you have any increased pain, decreased vision, you know, come in for a checkup.
I think anyone who's showing up to work or going to around their normal life and they have a red, painful, watery, photophobic eye, someone's going to say, can you not come into the office today and just go to the eye doctor and get cleared first? And I think that whoever checks them is going to say, what other products are you using? Who else have you been seeing? When's the last time anybody looked in your eyes? Okay, stop this, stop this, stop this. Only use this for now. We'll see you in a week or whatever it is. Thank you, too. We're doing follow-ups next? Okay.
Okay, everyone, we're going to start the next talk. And now we're going to go into the importance of follow-up visits and how these are important opportunities that you don't want to miss between yourself and the patient.
So the concept of a follow-up visit kind of seems like a no-brainer, right? Well, you don't just see them once in their lifetime and let them go, but you and the patient have to define this concept of a follow-up visit the same way. To many patients, it's, Doc, I'll follow up with you every 2 years when I get my voucher. But to you, it's got to be, you know, Mr. or Mrs. X, I'll follow up with you when it makes sense, depending on what it is that we're looking for here, whether it's risk of ocular complications from underlying systemic disease or medication, ocular problems of their own, or whatever other risk factors you think they have.
Yeah. And it helps to think about, you know, what are your endpoints during your exam? You know, starting with, you know, is this patient sitting in front of you, is this a medical exam? Do they have a medical complaint? Or are they here just for a routine checkup for glasses and contacts? And we know oftentimes we're going to find a medical issue that needs to be addressed.
I'll tell you that for the most part, everybody either has something or has a risk of something. Whether it's somebody is, you know, moderate to high myopia and they have a risk of, you know, stretching in the retina and retinal tears, whatever, peripheral retinal degenerative changes that go along with it, whether it's somebody has asymmetric cupping, mild ocular hypertension, thin central corneas. We haven't even got to the systemic stuff yet, or the pterygiums, congrectulas, dry eyes. So everybody either has or has a risk of something. And earlier on, we said that there are two pillars to the practice that we have. For the most part, there are two pillars. Other people have third streams of revenue, vision therapy, what have you. But for the most part, we have two. We have our medical pillar of practice. We have our optical pillar of practice. And when we look at the endpoints of the exam, so it's not just an open-ended encounter, right? There are certain endpoints we have in mind. One, is every patient a medical exam? So is there a medical diagnosis or medical concern that either is present in this patient or that there's a risk of in this patient? That's one thing to address. Two, does the ophthalmic product or device tie back into the medical management plan? And if you think of your lens treatment options, such as whether it is we're switching the type of contact lens you use because of your eye allergy type, or we're switching the type of lens you use because of your dry eye, or we're switching from your over-the-counter glasses to proper glasses that give you good UV protection because of the pterygium that you have, or we're going to recommend a polarized lens because of the cataract that you have, or things like that. Does it tie back into the medical management plan? Which in many instances it should. Is there a reason for the follow-up visit, or is it okay for the patient to say, I'll see you in 2 years, right? Usually there should be a reason for follow-up visit, and how can a patient's prognosis change negatively with no follow-up? In other words, can you just give a patient a sample of a tear and say, try this, if you feel good, there's more over the counter that you can buy, you don't need me, right? And if you don't feel good, come back. This puts them in that category where there's really no scheduled follow-up. The management plan is open-ended. You've taken yourself out by empowering them to just manage themselves with an over-the-counter product with a dosing regimen that just whatever seems appropriate to them. You basically said, patient, you can manage this condition as well as me. You don't need me. Now, what could happen to them? Could they come back with a bigger congrecula, with a bigger pterygium? Could they come back with maybe higher IOP or what have you because of the nasal spray that they were using for allergy? Or sinusitis, the nasal spray that they were using, and then now they come back with a higher IOP. You didn't follow them up. Primary doc's not following the IOP. Patient tells the primary doc, yes, I go to the eye doctor sometimes. The assumption is, okay, doc's going to monitor, the eye doctor will monitor the eye pressure. We're clear in that regard. What can happen to the patient? Can they come back with pressures of 30 plus? Yes, we've seen it, sure.
I mean, most patients with moderate to severe glaucoma, at some point in their life, they were mild. They were just glaucoma suspects. And those are potential missed opportunities for the doctor at that time to address their problem.
That's true.
Patients with severe allergies, they were mild at some point. Severe dry was mild dry at some point.
And that's the thing to keep in mind is we're seeing something that's in motion already. It started somewhere. You're not seeing it where it started. You're seeing it already in motion. And you don't necessarily want to see where it's going to end. Some of these 0.9 cup patients at some point were 0.3 and 0.4 cup patients, that over time progressed.
You also have to keep in mind, the patient's perspective, what are they looking to get out of this exam?
Right. So do we define the same, is this in your way? No, okay. Do we define the same thing the same way, right? The patient's coming in saying, well, my voucher's here, I need new glasses, I need new reading glasses, I'm not seeing very well, without understanding, but, well, you're not seeing very well because you have early macular degeneration. You have a mild cataract. You also have a chronic dry eye that's affecting your tear film composition. As far as they know, they just need reading glasses. I can't see well when I read, right? They don't know that they have all these other things going on. How much will this treatment plan cost me in terms of time and money? The time and money, they've already invested some of it with you. And if you don't give them an adequate management plan that makes sense to them and they place value on the follow-up visit with you, you've actually devalued the time and money investment. Case in point, we had a patient who came into us. We had another doc working with us before, who when they were new, I was in the next room and I heard him write a certain tier prescription for a patient. And he said, you're lucky because your insurance covers this one. And the patient actually got very upset. He pulled a bottle of the same thing out of his pocket and he got really upset. And he said, I took a day off to be here. I probably have a parking ticket outside to be here. I paid a $50 co-payment to be here. And you give me the same plan I came up with myself. So either I should be a doctor or you shouldn't. Which is it? The guy left very upset, and he was well within his rights. He what did he spend? An extra couple $100 if he told he needs the same tier that he's using?
All right, so the onus falls on us to show the value of what we're providing to the patient.
Right. So is the doctor concerned about my problem, and can I fix this without returning to the doctor? I'm not too big on recommending over-the-counter, eye drops, because right next to that is the over-the-counter glasses in the pharmacy, and now both pillars of the practice have been shot in the foot, to the ultimate loss of the patient. Not so much the practice, but really the patient, because we know over-the-counter glasses are one-size PD fitting, some people, I guess. The OC is exactly in the center of the B measurement there in those frames. Most people's frames aren't like that. I can see your line of sight's higher, so hopefully your optical center is not right in the center there. Hopefully it's in your line of sight. Otherwise you have unwanted vertical prism for no reason. So it's an important thing. Is doctor concerned about my problem? Well, if you don't give them a treatment and you don't follow them up, as far as they're concerned, I was fine. He didn't say anything. She didn't say anything. And some people come to you already knowing what they have. They will go to somebody else. They come to you as a second opinion, thinking the doctor can find it. Because what's their reference point? The reference point is the primary doctor who says, step on the scale, put your arm in the cuff, take a blood sample, urine sample. They send it to the lab and basically tell the patient what they have. The patient's not always complaining of, doc, I think my blood pressure's high. I'm not sure about my cholesterol and blood sugar. They tell them what they have. They don't know that your tests are not the same as in detail as these other tests that they're used to. They come to you thinking doc's going to do the tests and tell me what I have. Doc didn't tell me anything. I must be fine, right? And that's it. They're gone. Now you might think, well, they weren't complaining, so I didn't mention it, and that's where everything starts to go wrong.
Also, if you imagine patients with glaucoma, for example, from their perspective, they're not going to feel their eye pressure fluctuate. What will they feel? They'll feel the discomfort the drops cause. And oftentimes they may blame you. Doc gave me this drop. Now my eyes are red. Now they hurt. When I came here initially, I didn't have a problem. He told me I had a problem.
Right.
Now I feel worse.
Right. They'll think you either get the wrong medication, wrong diagnosis. I better get a second opinion. You've lost that patient. There's nothing wrong with your diagnosis or management plan, but maybe around bad communication, you lost the patient. So who defines success, right? Us or the patient? I think if we don't, the patient will come in defining success for themselves, which is I need to read properly, I need new reading glasses, whatever it is. You have to define success for the patient, right? Just like if they're going from an over-the-counter reading glass to a progressive eyeglass lens, the optician or whoever is going to educate them on the differences, the positives of this new management of their vision, some of the limitations they might run into. It's the exact same thing with medicines.
And part of the art of history taking is, how do you address all your concerns while acknowledging all the complaints of the patient and doing it within a short period of time. And especially now you have patients who are coming in with a preconceived notion of what they might have because of the internet.
Sure. Sure, Dr. Google, right? Tells them everything in the beginning.
So the goal setting at the initial visit, should be from your standpoint. That's where you take control of the exam, is during the history.
So here's where we get stuck. Sometimes, especially depending on your mode of practice. If you don't have a lot of medical equipment in the practice, if you're not really kind of active medically in eye care, and you're mainly doing optical management and giving tiers as you see fit, it's easy to fall into this trap of this misperception where if the patient's not complaining about it, I'm not really going to bring it up. Why do I want to open that can of worms for myself and the patient and maybe make them scared or make them feel bad? And then I'm not fully equipped to check these things anyway. It's easy to fall into that trap. And then the patient's sitting in the chair thinking, well, doc didn't really seem concerned about it. I told him I see a floater, and they said, it's normal. It's the same one you've been seeing all your life. Don't worry about that, right? That happened to me. I've been seeing floaters since I was a little kid. I went to Vision Expo West last year, and I was looking at different imaging devices for the new office. And what ended up happening? I go, oh, this is a nice wide field scan. We'll get up your retina. It's going to look great. Okay, let's see how it looks. And they took the scan. I looked at the image and said, oh, I have a tear. No flashes, no new floaters, no changes. I had a DFE 2 years before, a dilated exam 2 years before. I had no tear then. Right? So came home, got it lasered. What do you do?
Right, and that's a situation where you want to stress the importance of having your eyes dilated regularly.
We have,
even if you're asymptomatic.
We have a fourth-year student with us now who's doing a clinical externship with us, and she and I saw a patient who had a pre-tear. In other words, it was you could see where it was pulling and pulled up like a tuft, like a little tent, but there was no tear yet. Said, hey, you're on the verge of a problem. Come back within a week. You're probably going to need a little laser. Within that few days to where they came back, it had become a tear. You know, and we saw another person who had a tear as well, no detachment, no symptoms at all, but there was the tear, an inferior tear. So, you know, it's out there. And you think, well, I've been working X amount of years. I haven't seen a tear in my office. I do good dilated exams. Well, you know, if you've been working a number of years and you've seen thousands of people, look at the incidence in the general population of things like retinal holes, retinal tears, glaucoma. Look at the incidence of all these things. And if you're in your practice, what you're seeing is far below that, either you have an unusual practice demographic, or you might be missing some. You maybe need to step up the exam a little bit and the history taking a little bit.
Or if you're doing, you know, a contact lens fitting and you see the patient has some early signs of dry eye, but they're not complaining at all, you know, it's worthwhile to address it. You know, if you're only addressing their contact lens fit, they may come in once a year. But if you stress the fact that this can develop into dry eye, allergies, your contact lens wear may change on a seasonal basis, it warrants a follow-up.
Sure.
And patients will appreciate the fact that you're concerned about that and not just addressing, okay, they're here for their contact lens prescription. And we talked about earlier how patients who are asymptomatic or who have mild signs can progress to something more severe over time if you don't bring it up in the initial exam and they're lost to follow-up.
Right, so this is not an all-inclusive list, right? This is just a few common things that we see, but the thing to keep in mind is you're seeing something that's already in motion. You see fine pinpoint drusen. Patient has 20/20. They're not complaining. The vision's good. You know, do you enter into that discussion about macular degeneration? What happens if you don't? And they come back 2 years later with subretinal changes in one eye. It can happen. It does happen. We've seen it happen, you know. What if you see some corneal changes? Like you're starting to see, oh, they have some gutata. They might have an early fuchs. It's bilateral. It could be an endothelial dystrophy, maybe. What do? Do you bring them back a little sooner, or you just wait 2 years till they come back with this time 20/25 vision because they're having a little corneal edema now as they have more gutata now? What do? You know, it can happen. Dry eye, as Dr. Singh just mentioned, glaucoma suspect, right? Oh, well, you know, these are 0.6 cups, but I'm looking undilated, so they might look like 0.4 cups. You know, they might, you know, that's not really the way to do it. Diabetic patients, do you just let them come back every 2 years? Do you just say, hey, you know, I'm assuming they're seeing somebody else, or their primary doc sends them to the ophthalmologist or something? Maybe their primary doc does that because we're not doing our part. Maybe if the primary doc is getting a consult report back from us every 6 months that says, you know, mild non-proliferative diabetic changes, no neovascularization of the nerve, no neo elsewhere, and so on, no neo of the iris, no CSME. We'll watch 4 months, come back, educate the importance of blood sugar control, patient to follow up with you, pointing the finger back to the primary doc, so you make them stay relevant to the patient. Maybe if we're doing that, we might get some of those referrals. You know, if we're not doing that, then don't expect them, because then the primary doc will be on the hook for sending the patient to a provider that's kind of shown himself to be not really interested in this part of the patient's care. And besides that, I'm sure many other situations can come to mind. As we, you know, what's not up here is floaters, right? Floaters is a big one. Everybody has floaters, I would say. Even if you're not aware of it, you probably have a little something back there. Dr. Singh?
Can you guys think of any other conditions where you noticed initially either as a sign or patient has a mild symptom and you think it can potentially progress down the line?
And answer them in the chat too, other conditions that come to mind.
No?
Sure, cataract is one. Pterygium is another.
Right.
Very good.
So our audience mentioned the cataracts, pterygium as well.
Sure. So a follow-up visit, you know, what is it, right? It's a chance for you to see if what was an unstable situation before, whether it was elevated IOP that you started treating, has it become stable? Or if a stable situation, like, well, I do see floaters, or you have a new PVD, but nothing's happening, it looks okay, the peripheral retina is okay, you're flat, fully attached 360. You want to see if that stable situation has maybe destabilized over time. You need a chance to do that. If they're also, you could follow up with the patient about their systemic health, ocular health, systemic and ocular medications. Have they had any changes in vision that they're aware of or not? How many patients are a +2 for distance, but they don't wear a distance correction? How many patients have a 1.5 SIL but don't wear a distance correction? They're walking around seeing 85% all the time. They won't notice small changes in their vision. By the time they notice it, now they're big changes in their vision. You notice that. You put them in the phoropter and you'll tease that out, those small changes. You know, and of course, on the optical pillar side, well, broken glasses, new contact lenses, any change in any of these issues might warrant a change in some of the lens treatment options on the glasses, you know. So the optical materials really should be a legitimate part of the medical management plan as well.
Right, so, you know, as you have them in your chair there, this is your opportunity to instill value in that follow-up visit. You know, you explain to them that although you're feeling fine now, when I see you back next time, you know, this is what I'm looking for.
Right, you're defining success.
Exactly, you define success, you don't let the patient rely on how they feel to define it.
And the more clearly you communicate that on visit number 1, the more value they'll place on the follow-up visit. In other words, if they have to reschedule it or they miss it for some reason, they're more likely to take the extra step and confirm to rescheduling it as opposed to just blowing it off. You know, in the end, who's managing who? Is the patient managing the doctor? Doc, I'll see you in 2 years. Or is the doctor managing the patient? Listen, I need to see certain things at a certain time point. You know, it's almost like this. I mean, are my floaters a sign of something bad? And you're asking the patient, well, what do you think? Do you think it's something bad? That makes no sense, right? We would never do that. But sometimes without saying it out loud, that's what we are doing for other conditions.
Right. Your diabetic patient, they have no retinopathy. Does that mean that their risk of glaucoma or glaucoma progression is any lower? Does it reduce your need to do your glaucoma workups?
Does that mean that the inflammatory component of diabetes can't cause them an inflammatory dry eye or is not already doing it? Doesn't mean that at all. Right, so what motivates each side, right? I mean, you know, and I almost hate to say it, but you know, some of our, you know, patients have given reports to us about when they've gone other places and checked their eyes, how they felt. And they've almost felt like they were interrupting the doctor from some nonsense, from texting or playing games on the phone or silly things like that, you know? And the patient should never feel like they're interrupting the doctor. Should never feel like that. You know, dear doctor, I'm a little scared, but I told myself that if I'm still seeing spots, I mean, these are the thoughts sometimes that people are thinking, that the patient's thinking without saying them. You know, dear doctor, I'm a little scared, but I've told myself that if these spots that I'm seeing don't go away by my time of my next visit, I'm going to open this discussion and tell you that I'm seeing something, I'm experiencing something new, and seek your professional medical opinion. You know, sometimes the patient loses courage because they don't want bad news. So they're thinking this, thinking, well, you'll see it. If it's there, you're going to find it. I hopefully don't have to say it because they're scared. Because, you know, they Google things and they don't know what they're seeing. And in the end, everything leads to you could go blind, right? If you read everything on the internet, you're going to, oh my God, I'm going blind. You know, so.
For a lot of patients also, they're coming to you for a second opinion, but they're not going to tell you that because they're hoping that you're going to pick it up without them mentioning it. Right. Or they're afraid to mention it because they're hoping that's not the case.
Right. So, and then sometimes doc can be thinking, listen, you're keeping me from a game of something on my cell phone, so I'm going to keep this exam quick. I'm not really concerned what you have because whatever I write down, you're going to protect me in the end, right? Never, ever, ever be that doc, you know, and I'll see you in a year or 2 years or whatever when you get your next voucher. It doesn't really matter. I have things to do. Never be that person, you know, never be that person. And, you know, we've requested records sometimes for people and we've seen, okay, what's written here and what's actually happening here don't match, right? Did the patient really become a 0.8 from a 0.3 from last year? Or was a 0.3 just a safe finding to write down that the other doc doesn't have to take any action because 0.3 doesn't really warrant that, you know, anything if there's normal pressure and no suspicion of anything. I don't know, right? I'm seeing something in motion. Maybe this was the unusual patient that was a 0.3 last year and did become a 0.8 this year, but that's probably very unlikely. It's probably more likely that they were 0.8 last year too. And either nobody looked or somebody looked and said, you know, and just kind of did the wrong thing. That can happen. But it should not happen.
And now we're going to go over a couple of common conditions that we'll see in the office, and how do we warrant to follow up with the patient. How do we stress to the patient this requires us to take a second look or a third look or monitor you periodically.
Right. Trichiasis, we definitely see trichiasis. You know, these are folks that sometimes don't have trichiasis, they have dystichiasis, a second row of lashes that's growing there. Sometimes those folks need to be sent to the oculoplastic doc. That can be fixed. Sometimes they just need the lashes pulled for trichiasis. Sometimes they can do a little argon laser and actually stop the problem. Sometimes it doesn't work. You know, if you have a trichiasis patient that you're managing for glaucoma, do you want to give them something that might make their lashes grow more and maybe worsen the trichiasis? Might happen, might not happen, right? You don't know if you don't follow them up. That's somebody that I might follow up a little bit more closely than just for glaucoma alone. Ocular surface tissues, as we mentioned, you know, complicated contact lens use was at one point likely uncomplicated contact lens use. So you want to follow those patients up to keep them on the right side of things. Angles. Angles are a funny one. Who here does gonio on most patients? Yeah, right. Gonio is really valuable. It's a really valuable thing. Your main thing that we're looking at sometimes, the quick concern as well, is it safe to dilate this patient, right? Great. What's happening in the angle? Or do they have any peripheral anterior synechiae? Do they have any other changes in the angle? Is there a slight recession? Oh, they were hit in the eye before. Now I see something there. You know, take a look and see. Are the angles heavily pigmented?
Well, these are instances where, you know, on Van Herk, they look open, and then you throw in a gonio lens, you'll be surprised what you'll find sometimes.
Absolutely right. I'll tell you one thing. I saw somebody who had an iris cyst under a pterygium that you couldn't see at the slit lamp because there's a pterygium there blocking it. I put a gonio lens on, so, oh, what's this? You know, happened once. So lenticular changes, as we mentioned before, cataracts, lens changes, you know, vitreous changes, glaucoma suspect, macular, retinal changes, history of prior ocular surgery. As we had mentioned, you know, we think of surgery as a very controlled injury, risk of inflammation. Months afterwards, sometimes the tear film is still restabilizing, rebalancing itself. There's a chance for them to develop a dry eye.
Yeah, you may see patients with, you know, autoimmune conditions. They may have had a history of previous chronic iritis, although their eye is quiet in the office today. You look with gonio, you'll see some anterior synechiae. And that tells you, okay, in the past, your eye might have had an iritis. And it's worth investigating in the future.
That's right. Right. So optometric psychology, right? So it's easy to say if you're that, if for that doc that writes 0.3 when it's 0.8 sometimes, if for that person it's easy to say, yeah, but everyone has floaters. But the patient is young, and guess what? Patient is young is not a disqualifier. We saw a 13-year-old who with glaucoma in one eye. We have a young man who has, I think he's 8 now. He had congenital glaucoma. He's had glaucoma surgery twice with a pediatric glaucoma specialist with whom we co-manage, you know. But he is on IOP drops just like you would expect, you know, someone 10 times his age to be. Well, you could call the doc you saw last year, right? You know, in other words, do I have to do anything? Are you going to put me in this corner where I have to actually take action now? And then, but they weren't really complaining is not a defense. If you ever have to explain your position, your action plan or lack of one to your peers, they weren't complaining is not a defense. You know, could we sometimes find ourselves in a comfort zone where we just kind of look out to protect that comfort zone in terms of how we're comfortable communicating, the level of exam we're comfortable providing, you know, the quality of a referral letter that we might write to the next doc because that might expose that there are gaps in our knowledge. Are we staying in a comfort zone in these areas? And maybe not empowering the patient to really protect themselves. I think that could happen to anyone, right? Even if we're not always aware of it. So we have to be vigilant to not let that happen.
I think it's human nature too. When you're in a mode of practice for a long time, you become very focused in that area. The other fields that you're not so much experienced in, you begin to lose that experience and maybe even lose comfort with it. But it doesn't mean you don't bring it up to your patients. And if you need to refer out for it, and patients will still appreciate the fact that you noticed it, and mention that they should have a follow-up with it with someone else.
Right, so look at their primary doctor, right? Their primary doctor refers them out for pretty much everything. Refers them to every specialty. There are so many specialties, right? All of whom they can get to see after having been referred by their primary doc. So you're the primary eye doctor. There's no harm in saying, in fact, it's a reference point that they're already used to. I'm being referred to somebody else who knows more about this particular thing and is better equipped to test for and manage this particular thing. than my primary. Great. And what does the primary doc do when they send the patient out to another specialist? So we're going to give you a month to see him. We're going to see you back in 2 months. But we expect that during that time, you're going to have seen him, he'll have done his tests and treatment, whatever, and we'll see you back in 2 months and we'll have his report too. We do the same thing. So you're going to go to the retinal doc. We're going to see you back here in, I'm just going to say, with no particular condition in mind, we'll see you in 3 months, but I'm expecting for you to see him within the next 2 weeks, okay? We're going to call from the front, help you make the appointment within the next 2 weeks. You're going to see him. He has a chance to do his assessment, his treatment, his follow-up, and then we'll see you after all that with his report. They're used to that.
Right, like for example, let's say you're in a motor practice where you're ready and able to treat ocular surface issues, but you don't have the equipment to address glaucoma. And if you see patients with narrow angles, you send them out, but tell them, if the doctor does happen to have to treat you, I can oftentimes continue your care.
Right.
Or let's say, for example, they're put on glaucoma medication. We know glaucoma medication can lead to ocular surface issues. And let's say you're able to and willing to address those issues. You've now formed a relationship with someone else who will manage their glaucoma while you take care of the rest of the health of the eyes.
Absolutely right. Now, everybody in here has clinical experience of their own. Everybody in here will have some thoughts about everything that's in this presentation. So please, feel free to say or ask or comment or whatever it is.
Right.
So okay. Even if you're 99% correct, you do a great job. Only 1% error, right? 1% error. Let's just say you're a high volume place like we are. If you're seeing 42 eye patients a day, 5 days a week, 50 weeks a year, that's 20,000 eyes a year. 1% error means 200 significant mistakes a year. Is that okay? Does that 99% sound as good now? It doesn't, right? 200 mistakes a year? That's terrible. Everyone's important to somebody, right? My mother's important to me. Your mother's important to you, right? Everybody's important to somebody. We do absolutely owe it to our patients to empower them to protect themselves and try and keep that number as close to 100% correct as possible.
Now we're going to go into a little bit more detail about some of the different ocular pathology and how you can warrant a follow-up. We mentioned before patients with trichiasis. When you epilate and follow up to make sure they don't develop any corneal scarring, which can happen if you ignore the problem because they were asymptomatic.
Right. So, so here we see a patient, trichiasis. I mean, you could argue that this looks maybe like dystichiasis because of the positioning.
Mm-hmm.
It's a little further back, but the principle would be the same here. It's something that needs management.
Yeah. And when you epilate them, you mentioned, this is going to regrow, and that warrants me seeing you back in a few weeks to a few months to check that.
Dry eye, allergy, blepharitis, keratitis, and they're all listed here together because clinically it's not, dry eye only and nothing else, allergy only with nothing else. As we said before, it's oftentimes a mix of all of the above, weighted differently at different time points of the year. Ocular surface disease, we're looking at the lid margins, T-butt, meibomian gland dysfunction, Schirmer's we look at, staining we look at. One thing we mentioned before, staining is a valuable tool as well, looking for mild conjunctival chemosis as well. Short, intermediate, and long treatment goals should be established by us. And how often do we follow up? I would say as a rough guideline, 3 to 4 months, especially here in New York where we are, every season is different. Right? You go from now in the upcoming months, we're going to have hot, dry air indoors with cold, dry air blowing outdoors. Summer is the opposite. We have cold, dry air indoors with hot, humid air outdoors. There's no natural environment that, you walk out the door and the temperature, or you walk in the door and the temperature will change by 40 degrees. There's no natural environment on the planet that does that. That is an unnatural pressure on our eyes to adapt to that. It's not natural, that type of dramatic temperature change going from indoors to outdoors.
And then if you address, your patients should have, certain realistic expectations. We know different pathology will have a different regression as you start to treat them. And by establishing, when you're going to be seeing them back, a lot initially, and then hopefully as you improve, we'll see you less often, you're reinforcing the value of them coming back.
So let's just use dry eye as an example, right? So for those of us in the room, how often are we following up dry eye patients? And I'm not saying inflammatory versus not, versus tears versus, prescription product. Just general sense. What's the guideline? You think we should do once every 2 years, come back if you don't feel good, or what do you tell your patients?
Depends on the severity. Like 2 to 3 months for pretty severe dryness. And anything 6 months.
So depending on severity, somewhere between maybe 2 to 6 months, more severe, closer to 2 months, less severe, closer to 6 months. Sure, I agree with that.
Well, I think we all can agree, though, with at least in regards to what we talked about so far with the ocular surface, we're not going to give them a treatment regimen and say, see you back in a year.
Right.
We talked about pingueculas and pterygiums earlier. You want to establish the fact that this is not just a cosmetic condition. It is the source of your discomfort, the redness. Mechanical rubber will make it worse. You can recommend, eyewear recommendations.
Right. So here's an instance where if we think of the endpoints of the exam, are these patients medical patients coming in with pingueculas and pterygiums? Yes, right? Are there any concerns that we have about progression, about inflammation, about developing an inflammatory dry eye, and so on and so on? Yes. Are there recommendations that we can make as far as lubrication, prescription medications, UV protection? Yes. And do those recommendations help to tie in the optical material as part of the medical management plan? Yes, right? So it helps, certainly helps the practice by keeping you and your materials relevant on every front. But it definitely helps the patient as well. Because if this patient doesn't know that, they're going to go buy some vasoconstrictive drops. They're not going to read the part on the box where it says, if your eye is still red after 72 hours, stop using this garbage and go to the doctor, because the box went in the trash. And the bottle says full instructions, see box, right? So that's a bit of a trap there. Treatment goals that we might have around pterygiums and pingueculas, well, you're not really going to make it go away, right? Without surgery. And even if they have surgery, it might come back. So what are the treatment goals? We want to mediate the inflammation. We want to minimize the rate of growth, or hopefully, stall growth of the pterygium or pinguecula. How often are we following these patients up? Come back when you don't feel good. Come back in 2 years. What are we doing with them?
Every 6 months to a year.
Okay. I would say 4 to 6. And I'm just saying that based on being in New York, where the weather changes.
The seasons, yeah.
That maybe 4 to 6 is a little closer instead of 6 to 12. Plus, are you writing them a year's worth of prescriptions? No, right? So you're kind of guaranteeing them they're going to have some good months, followed by some bad months where the inflammation becomes worse, and then we're going to repeat again next year. A little sooner, just before they run out of scripts, it's nice to bring them back and see, are we going to refill the same, or can we change course?
And some of our, doctors watching online, they also agree that they'll initially start treatment and then follow up within a month or 2, and then 3 to 4. So as you mentioned before, a soon follow-up followed by more extended visits, depending on, how they respond.
Okay.
And here's just an example of a pinguecula on one side and an early pterygium on the other.
And this is nothing alarming, right? I mean, it's not as if it's, sight-threatening right now. There's no real aggressive inflammatory component right now at this snapshot in time. But that's the thing. We're seeing a snapshot in time. This is not like this all the time. Under different conditions, it won't look like this. So these are the things to think about when we make our recommendations about treatment and follow-up.
Right. And also, from the patient's perspective, because that day it's not bothering them, or that month because of the change in the weather, they're not symptomatic. They won't bring it up to you. But it's worthwhile to mention them. In the past, during certain seasons, does it get red in this corner? Does it become itchy? Do you rub your eye often?
And that's the thing too. There are symptoms and signs. Your history is not done until the patient leaves, right? Your history is going on the whole exam. So when I'm examining somebody, and like I mentioned before, it's easy to get trapped where you stay in the eye, you put on the cobalt blue light, which is just about the right size of the cornea, and you only look at the cornea. It's an easy thing to do, right? But have them look left, right, up, down a bit. You'll be surprised sometimes what you see. Depending on what stain you're using, you might see conjunctival staining, which in a dry eye will happen before corneal staining. You might even see conjunctival chemosis a little bit, which tells you there's an inflammatory component. And those folks, oftentimes, if you go back and you ask them again, okay, listen, I'm seeing that you have a little bit of swelling on the surface of your eye. Do you sometimes feel a little bit of itching in your eyes? And you just start asking them questions that have to do with allergy or inflammation. Now they'll start saying yes, yes, yes. Whereas before they said, no, I just need reading glasses.
And also, you know, with the population in New York, a lot of them have had surgery elsewhere, out of the country. They've had surgery before, and you're looking at the regrowth. And if you don't inquire about it, you can miss that. And also for the warrants, they need to watch them closely.
Sure. So here's a funny one, right? Angles, slit lamp versus doing real gonio. You know, I think a lot of us, we have our gonio lens from school, and it still looks brand new because we never use it. Do use it. If you don't, if you say, well, I have the one that has the little stem, I don't like the stem, get a new one. You know, a couple $100, get a new one then. You know, I have the one with the stem. He has the one without the stem. I've come to take a preference for that kind now without the stem, and then so I'll use his. But you know, concerns of the angle. What are we looking for? We're concerned about neovascularization. Who's at risk of neovascularization? Well, anyone with prior retinal vascular occlusion has a risk of retinal neo. The vessels creep forward, go right into the angle. Do look for that. If you start someone on IOP drops and you see it's not coming down as you would expect, take another look at the iris and the angle. You just might have missed a little bit of neo. You know, is there any angle recession to suggest they had a history of trauma that wasn't volunteered in the beginning? A closed angle, narrow angle. Is there an iris plateau? You know, does the angle look sometimes, yeah, it's open, but it's just too open. You know, what's going on here? Is there maybe a recession or something that is present? Remember the fluid flow dynamics. You know, you have the fluid that's produced in the ciliary body, comes through the pupil, over the front surface of the lens, through the pupil, anterior chamber, right out in the angle. If the angle's a little narrow, or you feel like you have a shallow AC depth, the angle's a little narrow, maybe it's not occludable now, fine. But as this patient becomes more presbyopic and the lens of the eye thickens a little bit more, fluid can start building up behind the iris there, not flowing as easily through that space between the iris and the pupil, pushing the iris forward a bit, narrowing the angle a bit on the front side. You know, that's something that can happen.
Also, you'll see, you know, young, healthy patients with unusually really deep chambers. It's worthwhile to look for pigment dispersion. These are patients who can now develop glaucoma as they get older. Posterior synechiae versus peripheral anterior synechiae. Good to take a look. You know, this zippering of the angle maybe isn't the best term, but the idea is that if you see some synechiae now and it's kind of a borderline angle that over time might become more narrow, the idea is that you might get more synechiae in the future, leading to an angle closure over time. You know, so gonio, you take a look at the angle and say, well, it's not straight ciliary body all the way around, or it's not straight trabeculum all the way around. It's kind of, you know, here and there, patchy, maybe a few little synechiae here and there. There are some processes. Are these processes or synechiae? I'm not sure. You know, when do we follow this patient up? 50-year-old patient, +1 for distance, +2 1/4 for near. You know, when do we follow this patient up? Do we tell them to come back in 2 years? Do we tell them to come back in maybe 6 to 12 months? And we take a look. I think 6 to 12 months is reasonable. And you take a quick look. You know, is this a patient that after they're dilated, maybe you recheck the pressure and you see as tissues bunching up in the corner there, what's happening? Is the pressure going up a bit? You know, I might follow that. That might help me determine if I want to be a bit closer to 6 months or a bit closer to a year. Right, like we know we're going to make the call for recommending peripheral iridotomy if they're narrow in 2 quadrants. But what do you do in cases where they're narrow in 1 quadrant? Is it worthwhile to re-gonio them in 6 months and see if it changes? You know, to establish sort of a rate of progression for yourself.
And if they've already had a peripheral iridotomy in the recent to intermediate past, is it guaranteed to stay open, or do they close sometimes?
It can slip further now.
They can close, and they can need a retouch sometimes. You know, so you look for that.
One of the doctors online has asked, you know, any contraindications to performing gonioscopy? Right, you know, if they have any active corneal infection, you may want to treat that first.
I think if there's anything acute happening on the cornea, whether it's infection, injury, you know, anything acute happening on the cornea, I would be a bit careful about doing any type of contact, you know, procedure on the cornea. Is that a hard contraindication? No, it's probably, you know, at best a case by case,
Yes.
you know.
Very good question.
So here's one that we're looking at. It's wide open in some areas, but you know, there are a few processes in some areas, but there are some peripheral anterior synechiae here and there. You know, so here's exactly what we said, 6 to 12 months. You know, might be a little closer to 6 depending on what you see, or if the pressure's higher, significantly higher after they're dilated, might be a bit closer to 12 if it's not. You know, practice, right? That's why it's called practicing, because the more you try to practice perfectly, the better you'll get. If you haven't done gonio in 2 years, well, when you do it, it's going to feel like your first time. Keep doing it, it won't keep feeling like your first time. You know, you'll get better and better and better at it.
You know, when we look at the lens, what are some of the things that we're considering? You know, do we just look at visual acuity? Are there other things to consider? We're looking for pseudoexfoliation, of nuclear sclerosis, posterior capsule cataracts, cortical cataracts. All these things can play a role in the person's subjective vision. Do we have any diabetic lenticular changes?
Is there something called a diabetic cataract? There is. There is. It even has an ICD-10 code, right? As a diabetic cataract. There is such a thing. Has anyone seen a diabetic cataract before? Not diabetic with a cataract, but a diabetic cataract, yes? Yeah, if you haven't, you know, look again. Even in sometimes young people that you don't expect to have an age-related cataract because they're young, you'll look at the lens and see, oh, it's got all these kind of speckled opacities going through, and it's just a little bit cloudy throughout. This is diabetic cataract.
Or you may have a patient with a mild cataract and borderline narrow angles. You know, we know as the cataract grows, it will shift the iris anteriorly. It's worthwhile to mention that to the patient.
Absolutely.
You know, this is another reason that we have to watch you as your cataract progresses.
Absolutely. You know, so we think sometimes, you know, we're in the exam room, we have a nice, you know, autophoropter, we have a nice bright projection screen, you know, that the patient's looking at in a dimly lit room. These are optimal conditions, right? These are optimal conditions. Just because they see 20/25 or something under those conditions doesn't mean that cataract is not of visual significance under other conditions. That's why sometimes pre-cataract surgery, the cataract doc might do glare testing to see how precipitously does the acuity drop under conditions of glare. And these are folks who you'll ask about night driving, and they'll say, oh, I don't do that anymore. I don't feel safe doing that right now. But now it becomes more significant. It's things to do, but I can't do them now. This is now maybe impacting your daily activities a little bit. Maybe have the cataract doc take a look.
Or oftentimes too, you're doing pupil testing, pupils are fine. You go to dilate them and you notice some posterior synechia. Depending how severe it is, you may be worried about an iris scar and ankle closure.
DMV requirement, you know, that's one thing that brings patients in sometimes. And I'm not in for a full exam, I'm just here for this. And some of the opticals around charge the patient $20 or whatever it is just to sit in the chair and read the DMV letters. I don't really think we should let them do that. I think we should always encourage them to get a full exam just because they can see 20/40. You know, and it puts the doc in a bad, awkward spot too, because technically you saw them, you know, but you advise them to do the right thing. Hopefully they will. Glare, you know, glaucoma. You know, we have glaucoma specialists that we refer to, and they've sometimes recommended cataract surgery along with glaucoma surgery for the patient as a space procedure. You know, the idea being that if you have the same amount of fluid in more space, it's under less pressure. If you have the same amount of fluid in less space, it's under greater pressure. You know, so that's the way that it was explained to us by a glaucoma surgeon that we know.
Because although, you know, when we're diagnosing glaucoma, we have strict definitions for each. A lot of patients will have what we call, you know, mixed mechanism glaucoma, where there is a narrow angle component to it.
Right. So here's somebody that could easily read 20/25 plus in the chair under controlled, you know, conditions in the exam room. But under other conditions, we can see how this lens with this type of opacity would significantly compromise their vision and give them glare. vitreous changes, asteroid hyalosis. Anyone here seen asteroid hyalosis? Sure, I think we all have by now. One thing to ask the patient if they didn't volunteer that they were diabetic, ask them. If they are, there's a link there. Vitreous cells, you can look inferiorly. You might see snowballing, where you have this kind of aggregation of material inferiorly that's settling down. Pigment in the vitreous or hemorrhage as a sign of potential detachment. Degeneration. Now, we were taught that, I think we were all taught that if you see any kind of a vitreous hemorrhage, you have to really look for the retinal tear. You have to look for the detachment. Look for it. Definitely look for it. You might not see it every time. You can have a PVD that causes a tiny bit of a vitreous hemorrhage. I'm not comfortable to be the last person to say that, so I like to just say, listen, I don't see a tear. It's probably just the PVD that caused this little bleed, but there is a little bleed. Let's just have the retinal doctor take a quick look and make absolutely sure that there's nothing else there. Because that's something that you can't defend your position, right? If it turns out the patient did have a problem and for whatever reason you didn't see it, you can't defend that position if you have to. But there was a vitreous hemorrhage, right? But you didn't send them anywhere. You can't defend that if there ends up being a problem in there.
And talking about PVDs and retinal breaks, these figures I pulled from the Academy of Ophthalmology practice patterns guide. And with fresh posterior visual detachment, there's about a 2% risk of a retinal break. Now, earlier we had talked about, missed opportunities. If 1% of your patients had this issue, 2% out of 200 is for patients that you could have missed a retinal tear. And on top of that, after the initial tear, there's about a 5 to 14% risk of a second one.
Which is huge. So if you start thinking about this and you say, well, this is year 10 for me working, I've seen tens of thousands of people and I haven't seen this once, there's a possibility that you might have missed one. So it's easy to say, well, is it a new floater? No, it's the same one I'm seeing. Are you seeing any flashes? No. It's as if our line of questioning can sometimes justify us not having to take action, or not having to invest a bit more time in this patient encounter. Not the way to do it.
What we'll do often routinely in the office is if we're not seeing anything with our 20-ocular lens, we'll use a 160 quad superfill lens.
Right. So I'm pretty good at BIO. I'm sure by now we're all pretty good at BIO. But I'm not equally good in all quadrants with BIO. And I don't think that everybody's equally good with each hand with BIO. And I can tell you that most patients are not that good patient for BIO because position this way, position that way, don't move, don't blink, hold still while their eyes getting dry. How many times do you finally find it again to figure out what it was? Can't really find it again. I found it, and the patient's getting uncomfortable before you really have settled confidently on what's happening, right? What it is. That happens every day. So what we do a lot more of is contact fundoscopy. Now, it's so controlled. Now, instead of using the 3-mirror gonio lens, which we all were taught, to use that, and you rotate this thing around and around, we started using the same laser lenses that the retinal doc might use to laser what he finds. Our thought process being, if it's good enough for him to fix it, it's good enough for us to find it, right? So our lens of choice is, this is not being biased to any particular product. It's made by Bolt. It's a Super Quad 160 lens. That's what it's called. It's probably between $800 and $900 to buy. It's not a cheap lens, but you don't have to rotate it. You get a 160-degree view without tilting the lens. So it's at the slit lamp. It's as controlled as if it's as controlled as it can be. The patient position is fixed. Their eye is fixed on my ear, or I tell them to look at the top of my ear, bottom of my ear, tiny bit left and right as I move the lens to get that full 180-degree view. If I need to stare at something for 5, 6, 10 seconds, while I figure out what I'm looking at, I can. So that's I mean, I think our incidence of finding pathology or at-risk pathology has gone way up.
Yeah. Because instead of shining a spotlight in the retina, you're pretty much highlighting a larger field of it.
Yeah. Other companies make similar laser lenses. You can, next time you go to one of the shows, maybe just go and pick a few up and play with them and see what feels good in your hand. But
you might have mentioned that the retinal surgeons use this lens anyway when they're treating, so why not use it to look for it?
Right. So just an example of vitreous changes, something you might see. You might see how asteroid hyalitis might look as you look back there. Now asteroid hylitis, we think of it as being very benign, but for some people it does worsen over time, and their acuity goes down and down and down. Those are folks that you want to catch that, send them to the retinal doctor. They can have a vitrectomy and really improve their quality of life. They'll see so much better afterwards.
In patients that you suspect of having glaucoma, either because of their angles, asymmetric cupping, history of chronic iritis or other forms of ocular inflammation, and history of trauma, family history, they're diabetic. These are all different reasons that you can warrant following up with them to do a glaucoma workup.
I mean, think of when you get in trouble. You get in trouble, if you don't do the right thing, or if you actively do the wrong thing, right? If you actively do the wrong thing. I think we're all aware not to actively do the wrong thing, but sometimes we're not proactive enough to where we actively do the right thing. And anything that's irreversible, like let's say vision loss from an optic neuritis, vision loss from glaucoma, vision loss from neovascular changes, these are things that we need to be very careful of, because that's where the patient can end up with a provable loss that can't be corrected, and you have no real defense against that. So remember, we said everyone either has something or is likely at risk of something. And glaucoma is a funny one. What do we look at to determine a patient's risk? Well, angles are one. We look at the cupping. That's another one. Family history is another one. Health history is another one. Medications they might use, things that could increase their intraocular pressure is another one. Patients that have risk of neovascular events, diabetics, vascular occlusions, pressure we look at, great. But how many patients have 0.8 cups and pressure to normal, 15 or less? Very normal, a lot, right? We see a lot of patients like that have big cupping or asymmetric cupping and normal pressures. How many people in here have really made the diagnosis of low tension glaucoma on patients before? If years pass and you haven't made that diagnosis and you're seeing a lot of patients with 0.8, 0.9 cups and pressure to 14, 15, you just might be missing it here and there. It's out there.
Especially if they have cardiovascular disease, diabetes.
Sure.
You should have a strong suspicion for it if you see a large cupping.
Sure. So, and what's the limitation sometimes? Is it that we're not well enough equipped in the office? Well, pressure we can do. Pachymetry, everybody have a pachymeter? Get one. If you don't have one, get one. It's a piece of the puzzle that's very valuable. That patient with a pressure of 17, if you do pachymetry, see they have thin corneas, corrected pressure of 22, now you view that same patient and all the findings for that patient differently, right? Because of that one test. So it's a valuable thing. Gonio, we talked about the value of it. Visual field, I think by now, either we're all doing a visual field or we should know where to refer to for a field. If you're local, we'll co-manage with you. We have all the equipment, so if there's anything that you're missing, we'll co-manage with you. We'll see them at 6 months. We'll see them at 6 months. Patient being seen every 3 months. Alternate visits due and that's fine. Dilated exam, fundus photos, very valuable. Do you ever put the photos up side by side from a couple of years ago and today and really look for small changes? You know what? This vessel is coursing a little differently. There's a little notch here now that wasn't there before. Let me put some filters there over the film. I now see a wedge defect that wasn't present before. Look for those things. Then you'll say, hey, you have low tension glaucoma. It's starting. Let's do a field and see if we see a matching structural and functional loss.
If you're doing OCTs and the optic nerve OCT looks normal, assuming they have a healthy macula, you do a ganglion cell count. You may pick up early changes.
Sure. 24-2
if you see borderline thinning in one quadrant, you do the ganglion cell count, you see a correlation loss there. It's a stronger suggestion for early glaucoma.
Sure. If you see maybe, there are a few little points here on the 24-2, bring it back to a 10-2, and see. Let that separate. Instead of every 6 degrees, it's every 2 degrees. You get more information. Now you might say, yes, I see a structural and functional loss that matches. This is the beginning of low tension glaucoma or damage from it.
You guys have any questions regarding glaucoma suspects?
But that's a big one. That's something that can change how we, work tomorrow based on how we think about glaucoma suspects.
As I had mentioned earlier, when you do see patients with obvious glaucoma, at some point in stage in their life, it was not obvious. It wasn't undetected. It was a mild glaucoma that progressed to advanced glaucoma. And it's an opportunity for you to step in and make them aware of it, initiate treatment. Because as you know, the more progressive glaucoma is, the harder it is to manage.
It's like a car. It's like a car that's rolling down a hill. You know, when that parking brake first fails at the top, someone can jump in and stop it, right? But once it's near the bottom with all that momentum, it's very hard to stop, right? Just to wreck at the bottom.
And once the patient's in your chair, you're now responsible for their care. Any successive vision loss they experience, although you know this condition started before you, they're going to hold you accountable.
Sure, sure. You know, so how did the patient get to that point of 0.99 cups and vision loss and high pressures, and they're still uncontrolled? As far as they know, they didn't even have a problem until now. How did they get to that point? You know, where did they go in recent years? Were they floating around, you know, different places where they didn't really have a comprehensive eye exam, even though they were told that they did, but it just wasn't performed comprehensively? Was it that somebody wasn't comfortable, you know, entertaining this discussion with the patient that you are at risk of a real problem and you need to go somewhere else? Let me make that appointment for you in the front, you know? Or did they fall into this category of, well, they weren't really complaining, they were seeing 20/20, they just wanted reading glasses, 2 years, whatever, and is that what happened? It happens sometimes, you know, or is there even an excuse? Because with today's technology, I mean, based on the entering, you know, we have the non-contact, the text doing non-contact pressure on the way in, text taking fundus photos on the way in, based on taking partial history on the way in, you know, based on all these things, I mean, we should really be able to know, to have a good idea of what's happening with the patient before they even sit down.
You'll be surprised. A lot of patients coming in their mind, they've heard of the word glaucoma. They were told they were a suspect for glaucoma. With their mind, having their vision checked, having NCT done, that's a glaucoma workup for them.
Yeah, right.
The doctor said my pressure was fine. Oh, I don't have glaucoma.
They think of NCT as the glaucoma test, the magic glaucoma test. It says yes or no.
It's important to stress that no, it's a series of tests that have to be done, and sometimes periodically. You know, some more numbers again. You know, we've seen lattice in the office.
This is a funny one, right? Remember we said you think of certain things, you know, what's the incidence in the normal population? And if you're not seeing it around that incidence, if it's dramatically lower, then you might be missing it.
So the perspective is, okay, so maybe not a lot of patients will progress from lattice to a tear, but think about the other way around. When you have a retinal tear in the office, almost 30% of them had lattice previously.
I think it's worth following those patients up periodically and letting them know if they have any new changes in vision, flashes, floaters, anything like a curtain hanging in their vision, anything.
And going back to those 200 eyes that were missed, if 8% of them had lattice, that's almost 20 patients that had lattice and didn't even realize it. You know, with macular degeneration, it goes above and beyond just checking this central vision. The recommendations are going to be UV protection, maybe recommending vitamins for the more advanced cases, maybe a consultation with retina, maybe a periodic macular OCT visual field.
Sure. And then do we communicate with the PCP that a patient has macular degeneration? Do we do that? I think we should, right? I don't think we always do it, but I think we should do it. You know, why? Because if the primary doc has them read the eye chart every now and then in the office and says, oh, they're seeing 20/20, and doesn't know that they have a risk of, they have mac degen with a risk of vision loss over time, they don't want to be left holding that bag if they know that, right? They're going to make sure that they come back to you periodically according to your recommendation for scheduled follow-up. And that's great, because when the primary doc has confidence in you, the patient's confidence goes way up in you. If the primary doc, if the patient goes, he wants me to come back in 6 months, I don't know why, and they go, no, you're seeing fine, I mean, whatever, you know, you don't need to go there, they won't go. They'll follow that recommendation.
Yeah, or if the doctor's treating them for diabetes and you wrote down in your report that they're at risk of normal tension glaucoma, doc will know, okay, although they feel fine, I need to stress them, they need to follow up with their eye doctor.
Absolutely. Now, follow-up versus referral, right? How often do we follow up? When do we, you know, turn the corner and refer these patients? Any changes in vision, I think we should refer to make sure there are no subretinal changes. You know, even if you have an OCT in your office and you say, well, I don't see any subretinal changes, it's still nice if there's a change in vision that you cannot attribute to anything else, such as media, cataract, corneal changes, dry eye changes. If you can't attribute it to anything else, then let the retinal doc take a look and make sure that there's nothing happening there. Follow-up, you know, I would say if it's uncomplicated, very stable, 6 months is fine. Other risk factors, let's say this is a patient now who has glaucoma, so there's a risk for peripheral vision loss. They're having the beginning of a condition that can compromise central vision. I mean, that's all we have, right? Peripheral vision, central vision, there's no other vision. That's it. But, 4 to 6 months.
Example of moderate to advanced dry AMD. We talked about your treatment options.
So epiretinal membrane, that's another one that we see sometimes, right? And it's not always easy to appreciate if they're not dilated, so it's nice to dilate and take a look. But, this is something that can, as it advances, start to compromise vision. If they're still seeing 20, 25, 20, 30, it's unlikely that the retinal doctor is going to go ahead and do a peel for them. That's unlikely, but it's still worth following up. I say every 6 months, looking for any changes in vision or looking for the beginning of a lamellar hole, anything like that.
Right, because although you may see it in the back of the eye, patient's vision is 20/20, it doesn't mean, okay, we can just ignore this for a year. It may be worthwhile to do a macro CT. You'll be surprised if you notice some subclinical vitreomacular traction that's not yet impacting the vision. And although in 1 to 2 years, 30% of them will resolve spontaneously if there is traction, what about the other 65%?
Sure.
And as we stressed before, all we have is our central and peripheral vision. And it's important to address both proactively.
Definitely.
And by educating the patient, they're going to be more compliant with their follow-up care.
So thinking about other things, right? When do we follow up patients who've had prior ocular surgery, laser procedures, maybe they've had some injections, they've had some focal or pan-retinal laser, strabismus surgery, cosmetic or reconstructive oculoplastic surgery. These are things, refractive surgery, we want to follow these patients up periodically, not only for dry eye, but of course changes in vision. Laser PIs can close. They might need a retouch sometimes. And sometimes the PI alone is not enough to avoid them having increased IOP over time and needing other treatment. SLT or ALT, these are glaucoma patients, should be followed on a 4 to 6 month basis as long as they're stable. Sometimes they need a second treatment, sometimes they need medicine as well. After cataract surgery, you're following them looking for opacification on the posterior surface of the implant lens. You're looking for, of course, any other changes that could compromise their vision that are related to the systemic health history. And also, if it's recent cataract surgery, you're looking for dry eye over time, or in the initial few months. Anti-VEGF therapy, you're monitoring the underlying condition that set them up for the anti-VEGF. Focal versus PRP, well, you're looking again for new changes, new neovascular changes, new edematous changes. Strap surgery, usually if it's a young patient, they're following up with a strabismus surgeon as well. But in the case of oculoplastics, these are patients that you might have referred in many cases for ptosis repair or what have you, or a treatment for distichiasis. These are patients that you should follow up as well, not just, oh, well, you're under their care now. We'll see you when we see you.
A lot of times you're seeing these patients initially, you're going to be the one that suggests these treatments for them. If you're going to prepare a patient for cataract surgery, you want to make sure their ocular surface is healthy. A lot of patients now are doing pre-IOLs, and we know the ocular surface plays a huge role in their visual acuity. If the patient has uncontrolled dry eye, it's going to throw off their vision results from surgery. And a lot of cataract surgeons nowadays will leave the ocular surface treatment to us.
Sure. Let's just, as an example, something very common, if you have a diabetic patient that has mild background diabetic retinopathic changes, quick question, yes or no, do they need follow-up? Yes, right? We don't just say come back in 2 years or go to your other doctor. Can we guess how their fundus looks 6 months before? No. Can we guess how it's going to look 6 months from now? Not necessarily, right? So we should follow them up, and 6 months is probably a good window for that. The take-home thing being from this part is you're seeing them in a snapshot in time. There's no easy telling if you just let more time pass how they will or will not progress negatively. And then they'll be thinking, but I've been seeing you all this time. Why am I progressing? Why are you telling me about this now? You know, you don't want to be on the receiving end of that lecture from the patient. You know, so. Yeah, I think it's a win-win. Definitely a win-win. Patient wins, doctor wins.
And also, you know, our online audience also agrees as far as, you know, corresponding with primary care doctors. They all agree that it's a huge practice builder and it builds a bond with the patient and with the other physicians.
So as far as communicating with the primary doctor, you know, consult reports are a great way to do that. Anyone sending consult reports out? Excellent, excellent. I think more of us should do that. It's not that complicated, especially if you just dictate it. It's really easy. You know, if you very, very important. They'll know that you're managing things that they're not managing. Because if they go to the primary doctor complaining of ocular surface discomfort, primary doctor's going to give them a tear or an allergy drop. That's it. Or an antibiotic drop. That's it. If you say, listen, but we're managing the patient's dry eye, they have or might need plugs, they have been given some prescription medication because of the inflammatory component of their dryness, these are things the primary doc's not really going to monitor. These are things that they'll be happy you're taking over for them, and they'll make sure that they, you know, co-manage this case with you.
And ultimately, you know, we both win, the patient and ourselves.
Okay. Any questions? Okay. So, do we have any questions coming in? I'm sure we'll have some questions coming in online.
Yeah, I'm going to check that now.
So, we'll take a break, then we'll do the third part.
Okay, so for those of you viewing online, if you have any questions for us, you know, please send it to us either in the chat or you can send it privately in the Q&A segment. Well, I find that the most effective way to convince patients that a follow-up is necessary is by addressing, one, what is it that you suspect that they have? What do you think is the risk of it progression? If it's not asymptomatic, why does it have no symptoms? And if there is a risk of it progression, you know, how will it impact their vision? If you stress to the patient, look, you may have signs and symptoms of glaucoma. Glaucoma is potentially a blinding condition. So although you're seeing perfectly well now, if we don't monitor you closely, this could spiral out of control. Patients will be more compliant.
Hi, Christine. She's here.
So, in practice, it won't always work. You won't always be able to communicate, to get somebody to hear, no matter how well you say it, they won't always hear it the same way, that they need to come back, or there's some risk of sight-threatening condition. But what you do is you let them know. You let them know what they have and where you feel the condition is going. Once you know what they have and where you think the condition is progressing to, you can probably guess where they were at some time period before. And if you can say, listen, this often starts off with symptoms like this, and whatever they're noticing, this often starts with, let's say, in the condition of a cataract, right? For example, you could say, this often starts with really no symptoms, but then people start noticing things like changes in their eyeglass prescription, and then a little bit of glare at nighttime. The oncoming headlights of cars bother them more than before. And they'll say, then they can identify with, okay, where I was. You're telling me where I am right now. Well, you were right on 2 points, so you might be correct as well on point number 3 about where this condition is going. And then maybe it makes more sense for me to come back, at the specified time frame for follow-up. And even with all that, with great communication, you will not be heard the way that you want 100% of the time. All you can do is do your best, and that's really all you can do, is do your best. But I try to identify with the patient in terms of where the condition likely was, by mentioning symptoms and signs that they might have noticed in the past, and then I can tell them the reason they're noticing certain signs and symptoms of the present, and then try and show them where this condition can go without intervention or without follow-up in the future. And sometimes it works, more often than not it works, but sometimes, it doesn't always work. But you do your best, and your rate of retention of follow-up patients will increase over time as you refine your communication skills, and you communicate more confidently with them about the follow-up visit. Because part of what they're reading from you is not just what you're saying, but they're reading how confident you are in what you're saying. And if they feel like you're not that confident in what you're saying, then they're less likely to evaluate. But that was a great question. Thank you.
Right, so I just unmute it. So I can sleep.
It's okay. Okay.
Huh? Very good.
Good. Yeah. Too much. Yeah, stop it. Stop it. Stop it. Stop it. Yeah, but I don't want to keep changing automatically. There you go. Okay. Ready? Six hours to go.
Darren, Charlie, can you start up on one chair?
Wait, I had all carbs here today. I had a bagel and then a little pasta. A little sort of.
Okay, everyone, we're going to start our last talk for today. And the topic now is going to be uveitis. We're going to explore how uveitis affects different structures in the eye, from front of the eyes to the back.
Uveitis from front to back. Okay, so uveitis, what and where is it? According to the CDC, about 10% of all cases of blindness in the United States are caused by uveitis, right? Very significant statistic. We think of how many patients do we see with uveitis or who are at risk of uveitis, and we were talking before about follow-ups and progression of conditions and what are the end roads of certain states if left untreated. And if we think of uveitis, wow, 10% of all cases of blindness in the U.S. can be attributed to uveitis. Very significant. What is it? Inflammation of the uvea, the eye's middle layer, which is made up of the iris, ciliary body, and choroid. Iritis is the most common type of uveitis. The ciliary flush, characteristic sign that you'll see, hallmark sign. We think of uveitis from front to back as being anterior, intermediate, or posterior. Now, intermediate uveitis, we can call parsoninitis or iridocyclitis. When you have inflammation of everything at the same time, we call it panuveitis.
And although we have these distinct definitions and names for uveitis depending on where in the eye it happens, we're going to show how there's a bit of overlap. And there's overlap in treatment also.
So signs and symptoms of uveitis, we think of photophobia, light sensitivity, maybe a blurring of vision. We also can notice changes in the intraocular pressure, can go high, sometimes can go a little low. Symptoms, can be rapid onset or delayed onset. Blurred vision, the acuity can vary. You can have somebody with a little bit of uveitis coming in saying that their vision is blurry. Other folks who have a pretty significant, anterior chamber reaction and the acuity is surprisingly good. They may complain of floaters, they may complain of reflections, eye pain that tracks back to the photophobia. That's where the cycloplegic agent can sometimes be helpful. Redness, photopsias in posterior uveitis. You want to ask in the history about history of recent eye surgery or ocular trauma. Is there any infection that they're aware of that activates from time to time? Signs, well, ciliary flush, we said, cells and flare in the anterior or posterior chamber. Hypopyon, deposits on the corneal endothelium on the surface of the lens, which can give you, precipitates, which can give you an idea of how long and how aggressively this has been going on. Pupillary irregularities, which can give you from posterior synechiae, for example, and iris color changes from recurrent or chronic uveitis.
And we're going to explore later on, how these various signs will present themselves in the eye with acute uveitis, chronic uveitis, and depending on the etiology, whether it's autoimmune, infectious, due to trauma, surgery.
I'll tell you that routinely, when I look at the eye, I always turn the mag a little higher, even if they're not complaining of photophobia, no ciliary flush. I don't think I caught a glimpse of a cell or something like that. I still turn the mag a little higher and look, especially if there's anything happening on the cornea. If they say my eyes bother me a little bit and it's just kind of a non-specific complaint, I'll always take a look at the anterior chamber and the anterior part of the vitreous just to look for cells. And sometimes, you know, maybe not that often, but sometimes you will see some that you could have missed otherwise.
You know, we're going to also explore some of the complications you can expect to encounter when patients experience uveitis. Here we talked about the changes in eye pressure. When we're thinking of glaucomatous uveitic glaucoma, we'll have a pressure spike. But in cases of an acute iritis, sometimes the pressure will fall because of a reduction in function of the cellular body.
So complications, so we're talking about untreated uveitis. These will vary depending on the location, the intensity, recurrence, duration, and also when treatment was initiated. Band keratopathy is one. Of course, synechiae, anterior synechiae, narrowing or closing of the angle, as you can see, if you had recurrent uveitis or chronic uveitis. Posterior synechiae, leading to the risk of a pupillary block. Uveitic glaucoma, which is a bit of a sneaky problem that you need to be alert for and vigilant about if you do suspect it. Cataract, macular edema, retinal detachment if you have fibrosis in the posterior segment, and vision loss.
Right, so these are all potential complications that you'll have to bear in mind and continue to look for after you've managed the acute problem. Well, first of all, you know, we'll start off by talking with anterior uveitis.
So, you know, sometimes iritis and anterior uveitis, these terms we use them normally interchangeably. You know, try and call it what it is. I mean, if you're saying anterior uveitis, it's really inflammation of the uvea. So, you know, I would call it anterior uveitis. Hypopyon, you might see if it's very aggressive or it's been lingering for a while. Common categories, we think of granulomatous versus non-granulomatous. Etiologies, in about 50% of all cases, no clear associated condition is identified. So about 50% of all cases, it's idiopathic. We're not really sure why, but that's why if it's recurrent again and again, definitely send the patient for some blood work. You know, how often does it have to be? Well, if it recurs twice within 6 months, 3 times within a year, twice within a month, I'm not sure. But if this has happened a few times, let's say if I look back and even in the last couple of years, this is, let's say, episode number 2 or 3, we're going to go ahead and order some blood work for this person. Infectious versus non-infectious etiologies. Non-infectious etiologies, we think of the autoimmune diseases, the same conditions that could give us the risk of an inflammatory dry eye, we would think of as having a risk of getting a uveitis. Infectious, well, herpetic keratitis, CMV, retinitis, believe it or not, even Ebola. You know, 20% of those cases, those patients would have a uveitis as well, anterior uveitis as well. Herpetic keratitis, unilateral SPK with anything happening in the AC, suspect herpetic until proven otherwise.
A question I pose to the audience is, what type of uveitis do you think is most common? Is it anterior, panuveitis, posterior uveitis? Anterior. Right, so in a lot of cases, really, the first time it sees them.
Sure. So moving back from anterior, moving posterior in posterior direction from front to back, intermediate uveitis. You know, sometimes we see a vitritis. So does vitritis mean that the vitreous gel is actually inflamed? Not inflamed, but you're seeing the presence of cells in the vitreous cavity. So the term vitritis is really descriptive. It's not really a condition in and of itself. Pars planitis, you may see a deposition of inflammatory material on the pars plana, and iridocyclitis, presenting as anterior uveitis plus a vitritis. You may look for snowballing or snowbanks, really aggregations inferiorly in the, if you look in the posterior segment of the eye and you look at the bottom part of the eye, you might see some aggregation of inflammatory material there that's settling.
With posterior uveitis, you're going to notice inflammation of either the choroid or retina. Like in case of chororetinitis, oftentimes it's going to be non-infectious in etiology. You're thinking of autoimmune condition. In infectious cases, the most common one is going to be toxoplasmosis. You know, if you see these choroidal lesions, you can look for any active inflammation around them.
So that's important to remember because we touched on toxo before. The most common infectious etiology for when you see a posterior uveitis, toxoplasmosis. Really look around for that lesion. Look around for that lesion. Look, see if it looks like it's fluffy white. That suggests that it's active. You know, that's somebody who you could give them a topical steroid to help with the uveitic component, the anterior uveitic component. But really, they're going to need some oral medication that's going to, Daraprim or something similar, that's going to help to kind of quiet it down.
The question you may ask yourself is when you do see cells in the anterior chamber, you see cells in the vitreous, is this an anterior uveitis spilling over into the vitreous? Is this a posterior uveitis spilling over into the anterior chamber?
Sure. Sure. So if you see a patient with a non-active toxoplasma lesion or chorioretinal scarring from toxo in the back of the eye, do you tell them anything about it? Do you tell them anything about, what do you tell them?
I tell them about the lesion and that it's important to monitor it because it can become active at any time.
Sure, sure. And then what signs of or symptoms of reactivation do you tell them?
Any sensitivity to light.
Really, uveitis, right? You're describing uveitis to them. You're saying, listen, if you start noticing these symptoms of uveitis, come back. And then what are you going to do? Well, you're going to help to manage it, of course. But you're also going to watch for the sequelae of uveitis, pressure and what have you, all that stuff. Absolutely right. You know, we had an interesting one last year. A young lady, she was pregnant, and she was having her episode of toxo as well. Right? Yeah. So we co-managed her with her OB, and who co-managed her with a high-risk OB, and in the end, healthy baby, healthy mom, everybody's good.
Right, because you know, in those cases, you're really managing the anterior inflammation, while the primary may want to put them on oral antibiotics.
And so while you can say, well, toxo is self-limiting, you don't need to do anything. Well, if you just let uveitis run wild for months at a time, which would have been the case for her, because it would have just run for months, all those sequelae become very real.
Right. Yeah.
You know,
You may not be
so-
managing the infection directly, but you're still looking for retinal detachment. You're still looking for macular edema.
CME, IOP, all that stuff.
Now, in this slide, you know, there's a whole slew of non-infectious etiologies. By and large, most of them are autoimmune in origin. For example, with Behçet's, with Wegener's is not called granulomatosis with polyangiitis. These are vasculitic disorders. Sarcoid, lupus, these are multi-system autoimmune conditions.
Right. So most of what's on this list, really all of what's on this list, you know, we're co-managing with rheumatology or the PCP and rheumatology. You know, while you're managing the ocular component, PCP is managing the overall patient. Rheumatology is managing the inflammatory systemic disease component.
I guess, you know, a peace of mind, at least in only in a minority of cases, is your posterior uveitis going to be infectious. Most of the time, it's going to be an autoimmune condition.
And that's, you know, that's where contact fundoscopy becomes so great. I mean, think about it. The patient's looking down to the side. The tear prism is collecting there as well. They're tearing a bit because their eye's drying out and the bright light's bothering them a bit. And now you're trying to determine if that toxo lesion that's small and way out there is just a little bit fluffy white on one border or not. It's very hard to do that with BIO. So looking at other etiologies, drug-induced etiology we often don't think about, but historically there have been some. Rifabutin was one. You know, there was one case that made its way into the literature about moxifloxacin. I've never seen it. I don't know anyone who has ever seen it, but there was one case that made its way into literature where they said possibly this patient had some unusual reaction to moxifloxacin that gave them a bit of uveitis. Looking at white dot syndromes, you know, occasionally uveitis, we're saying for the most part, it's a manifestation that within the eye of a systemic condition, but sometimes it can be confined to the eye without an underlying systemic condition that we can identify, and the etiology just stays unknown. You know, what type of thing? Well, there's AMPI, birdshot, multifocal choroiditis, and panuveitis. immune small epithelial white dot syndrome, punctate intrachoroiditis, serpiginous choroiditis, of which we have one patient in Hollis who has serpiginous choroiditis, and we co-manage him with a uveitis specialist as well. Acute zonal occult outer retinopathy. So, and again, if things are not following the normal course of resolution, or if it's just so recurrent, or you think this patient might need oral steroids, and now I'm worried about this diabetic patient's blood sugar getting out of control because of the oral steroids, let the uveitis specialist take a look. There's no shame, there's no, oh, I'm going to hold it so tightly and just give them more of the same medicine, or wait another week and see what happens.
I mean, the difficulty with managing the white dot syndromes is distinguishing between them. And there's a lot of controversy over whether these are all distinct syndromes or it's just one disease with a broad spectrum, within a broad spectrum. So it doesn't hurt to involve retina in rheumatology.
Sure.
And then from our standpoint, when we're managing the white dot syndromes, again, our concern is going to be retinal detachments and macular edema, and any risk of choroidal neovascularization.
So masquerade syndromes, conditions where intraocular cells are present, but it's not due to immunomediated entities. Two categories, neoplastic and non-neoplastic. Neoplastic, thinking leukemia, malignant melanoma, retinoblastoma, lymphoma, reticulum cell sarcoma. Non-neoplastic, intraocular foreign body, juvenile xanthogranuloma, retinal detachment, retinitis pigmentosa. And I did see a patient once. She came in with a pretty strong posterior uveitis. She had a shallow retinal detachment that had been there for a while. I didn't see it. I couldn't see it. She had a posterior uveitis that was spilling into the anterior chamber. Did not get better at all, any improvement at all within a very short time frame. Had a retinal doctor take a look because it was really this posterior segment spilling over to the anterior. Turns out she had a shallow RD that you really couldn't see because of just how hazy the posterior segment was.
And these are also cases where, if it's picked up in the blood work, you're also going to incorporate having an oncology specialist involved too.
So the main thing is not to memorize the list of conditions, right? Because that list of conditions is going to grow. The more sensitive and specific testing becomes, the more conditions are going to get added to that list, right? So it's not so much about that. It's about making sure that we understand when something, what types of situations this might be really limited to the eye, when it's a systemic etiology that we know of, that the patient knows they have, that might be manifesting in the eye, or we don't know what it is. This is part of that 50% of causes of situations that we don't know any clear etiology. It's not responding the way that it should. We have to have somebody take a look. There could be some other condition here that's masquerading.
Yeah, and then again, for the most part, we're managing, the risk of macular edema, retinal detachments, tears, angle closure,
that role is still there.
glaucoma. So we still play a role.
Can you go back one? Sorry, we missed one. Right here. So examining the patient with uveitis, right? So when we examine the patient, from the beginning, when the patient comes, you call their name and they come walking in, if they're indoors wearing sunglasses, maybe suspect that they're a little bit photophobic. If you see a ciliary flush, if they're telling you my eye's been red and a bit painful, can you lower the light before I take my sunglasses off? That's a pretty good clue. Of course, pupils, visual acuity, these are the norms. When you do a slit lamp exam, we're looking at the anterior chamber, but we're also looking at the endothelium for precipitates. We're looking at the optical clarity of the aqueous. We're looking at the anterior surface of the lens, as well as subtle irregularities in the shape of the pupil, right? Posterior synechia that could be there. IOP, high or low, vitreous, is anything spilling back into the vitreous or perhaps originating from the posterior side spilling forward? Now, we do our DFE, we do our MAC OCT. DFE, you're looking for anything that looks like maybe an RD that could be contributing to this. DFE, you're looking for any lesion, any infectious lesion that could be there, or any other lesion that could be there. They could have a choroidal melanoma or something that's sitting back there. And macular OCT, you're looking for CME.
The last question cut off there is, do you see any value in doing a visual field? Any thoughts on that? Maybe if you're questioning if the person has a concurrent optic neuritis with it, you want to do visual field. If they've had episodes of IOP spikes, has there been any glaucomatous damage?
Sure.
You know, this is like an example of once you get the patient out of their acute problem, now you're dealing with all the sequelae that come with it.
Any other thoughts on how we examine, not the workup and all that stuff, the blood workup, but just the examination of a uveitis patient? Any? Right. Anterior, posterior synechiae, right? Gonio. Also look for posterior synechiae pupil shape. You dilate them and you see, oh, the pupil is just stuck. The iris is just stuck in one section. It's not dilating. Clumps of pigment on the surface of the lens that show you they've had the posterior synechiae in the past. Sure.
Also, this might sound a little obvious, but you know, check the other eye. Although it's quiet, do you see signs of posterior synechiae, anterior synechiae? They might have had an iris in the other eye before. You weren't aware of it. So although it could be the first occurrence in that eye, doesn't imply that it's not a chronic problem. Actually, one of the conditions we talked about earlier.
We have a gentleman with ulcerative colitis that he has just recurrent episodes of uveitis in each eye, and they just go for weeks at a time.
This one condition here, sympathetic ophthalmia, that's an example of a person experiences trauma in one eye, which exposes the tissues of the inside to the outside world and develop an antigen. And then the other eye ends up developing the iritis months or years later. And they call that the sympathetic eye.
You know, Dr. Malikan, I think we saw one. One, yeah, of those. Where the guy had the injury to one eye, but he came back with an iritis in the other eye. Yeah.
Because you know these pro-inflammatory factors, they're systemically. This tubulointerstitial nephritis, that's an autoimmune condition where it's attacking the kidneys, but there's similar tissue cells in the eye, and the person will develop a concurrent uveitis also. So that's an example of, you know, if you don't manage their systemic health, the iritis won't get better, right? The question, you know, we proposed earlier is, so when do you order blood work? Do you do it after their initial visit? Do you do it if it comes back a second time? Or is it a case-by-case basis?
What do you think? Okay, so we're hearing case by case. And anything else?
I think most of us would agree that it's a little more complicated than yes or no, right? Case by case.
Yeah, case by case. I mean, after, you know, usually if, let's say if the first event, so the first choice says after the first event, right? If the first event is not getting better in the expected time frame or with the normal treatment, they're not improving, then we're going to go on to the next level of investigation. After the second event, I think after the second event is valid, even if it's improving normally. Why is this happening? You know, make a judgment call based on presentation. Sure. I mean, if you see that they have you know, clumps of pigment on the anterior surface of the lens to show that they've had this happening before, definitely you know it's not the first event, even though it's the first time you're seeing it with this patient. It's happened before, obviously. And then the last option, I never ever order blood work for uveitis, is just not sensible.
It also helps if you're trying to determine whether you're going to order blood work the first time around. You ask about their systemic health.
Sure.
You know.
Now, what do you do if you don't know what test to order, or you're afraid about, oh, what if I write the note to the primary doc and they'll see that I don't know what I'm talking about because I missed certain things, or I wrote down things that weren't necessary? That can be a valid concern if you've never made that type of referral before. It's okay to call the primary doc and say, listen, I have Mr. X here, and he has this recurrent anterior uveitis of the right eye, and I'm concerned that he has some underlying systemic etiology that we need to figure out. He needs to be worked up for it. You know, can I send him to you for the appropriate blood work? Yeah, sure. There's nothing wrong with that. I mean, Dr. Google can fill in the blanks if you need him to, but there's nothing wrong with sending him to the primary doc like that as well. So whether ordered by us or by the primary doc, what's the workup that they're going to undergo? Well, there's going to be a hematologic component and a rheumatologic component to the blood work. The hematologic component, CBC with differential, ESR, CRP, lysozyme, serum creatinine in the pediatric population. Rheumatologic component, ANA, rheumatoid factor, angiotensin converting enzyme with reflex chest X-ray, P-ANCA and C-ANCA. Is there any sense in doing an MRI? Good question. There can be. I mean, if you
I think so. I mean, if you've done the necessary blood work, it's inconclusive. You see any sign of disc edema, it may tell you there's something retrobulbar going on back there.
To continue the specifics of the workup, TB testing, HIV screening, RPR, FTA, ABS, herpes, of course, looking tick-borne antibody panel, immunologic component, HLA-B27, very common. We have a gentleman in Hollis with ankylosing spondylitis, HLA-B51, Stay's disease, and HLA-A29, birdshot.
Besides, although it's rare, it's actually the most common form of panuveitis. And the concurrent symptoms are going to be oral and general ulcers. Hence why, asking about the case history can help tease that out if you're suspecting it. And if you do your immunologic testing and patients do come back positive with some of these factors, it just further warrants the need to watch them periodically, even after you've calmed down the uveitis.
So treatments, right, depend on the etiology. We're saying for the most part these are systemic etiologies, so there's an ocular component and then there's a systemic component to the treatment. Antivirals, antibiotics, steroids, maybe non-steroidals. Remember, if we're thinking of a risk of CME, ocular pain, things like that, non-steroids have a role. Glaucoma, perhaps if there's an elevated intraocular pressure or uveitic glaucoma. Cycloplegic agents to aid with photophobic discomfort. Injectables sometimes for posterior uveitis, subtenons, triamcinolone. Orally, again, antivirals, antibiotics, steroids, NSAIDs, methotrexate sometimes, metformin in some cases, tramadol, infectious disease management, with an infectious disease specialist, if that makes sense. And it's not about memorizing this list, right? It's about you're managing the eye and you're aware that there's other stuff going on or a risk of other stuff going on, and you're sending out, as appropriate for that other stuff to have a chance to be followed up. Other treatments that were in development, derivatives of voclosporin, tacrolimus as immunomodulators, anti-VEGF, Avastin, etc. These are things that have a role if the patient's developing some edematous changes. Anti-tumor necrotic factor and gevokizumab, which is similar in terms of some of the other agents mentioned.
Yeah, again, it's if you're concerned about them developing neovascular changes. And this is going to fall in the realm of retina.
Okay, so we can theorize it and go through it all to death, but I think we're pretty well versed in all that. But what are we going to do differently tomorrow? Well, let's see how we would do some of this stuff if we were doing it today. Case number one, let's say we have a 38-year-old Asian male presents with a painful red left eye. He has an unremarkable systemic history at initial presentation. Associated symptoms include blurring or fluctuating vision, and his past ocular history shows a similar event almost 1 year ago with the same signs and symptoms. So first, is there anything else you'd like to know? So the 38-year-old Asian male, healthy, he's had this episode happen once before a year ago, but he's got some photophobia and blurring of vision. Otherwise, the systemic and ocular history seem unremarkable. Anything else you'd like to know? Good. When, how long? Right. Sometimes people say this happened to me before, but it cleared up after a week. I didn't go anywhere. Nobody took a look. And trauma is one, right? Did he get hit? Any history of trauma? Did anything happen? Any other systemic symptoms, even though he's healthy in the sense that he has no prior diagnosis, and the other systemic symptoms, And also, am I the first one to take a look at this? How long, has it been going on? Has anyone else taken a look in that time? What are the differential diagnoses that initially go through your head? Of course, uveitis, right? Uveitis. How do we counsel this patient on his diagnosis of uveitis? And that's important because what's the expectation, the reference point people have? I'm sick, I go to the doctor, I get some medicine, I get better, and I'm done, right? I don't take medicine, I don't go back to the doctor unless I feel sick again. This is different. This is something that there are sequelae to follow for. If there's a recurrent episode, we need to go and maybe order blood work or maybe send to a different specialist for a different type of workup. So all of that's part of counseling him on this diagnosis of uveitis. Treating him, I think certainly we can start with the norm, steroids, cycloplegic agent if he's very photophobic, non-steroidal if you think there's a risk of CME, a risk of pain. Any treatment pitfalls in managing this patient? In other words, is there anywhere that maybe we or the patient could kind of step into a trap?
They may not take the drops.
That's one. That's a big one. That's a big one. I feel better. I stop the medicine, and then comes back. Right? It's like a pendulum. I tell the patients, I say, this is like a pendulum. Right now, you're not balanced. You're inflamed. You're all the way up here. We're going to give you these drops. They're going to set you back to here. We're going to shut the response off. If we just let it go, well, what's the pendulum going to do? Boom. It's not going to stop in the middle. We want to taper you, and gently push you down at that balance point, right? That's what we want to do. So that he'll feel better, stop the meds, and say, oh, I got red again. This medicine didn't work. Doc misdiagnosed me, or the medicine was bad. I'm going somewhere else.
Right.
It happens more often than you think.
Or you might have a patient who comes in with the uveitis but with low pressure, and as you're treating them, they happen to be a steroid responder, which you can't really predict, right? So only 30% of patients may have it, and now you have to address the pressure spike. But patients, they should be aware that another reason why they shouldn't be lost to follow-up and not sort of self-medicate with their topical anti-inflammatory whenever they have discomfort.
That's the treatment pitfall too. You write them, let's say you think I'm going to taper him over the next month, right? We're going to taper him off slowly. So you write him a refill or 2 refills of his medicine. He doesn't come back for the follow-up. He has 2 refills of Pred or whatever you wrote for him. Episode, either he self-medicates and gives himself a problem, or future episodes he self-medicates and continues with an undiagnosed problem. So those are definite traps.
All the more important to, communicate with his primary care doctor or rheumatologist if he has one, to further reinforce the need to come back.
Yeah, when I do a consult report, I always say, at present, Mr. X is scheduled to come back in 1 month or 3 weeks or whatever it is. During that time, we expect him to do or to see whoever or see you or whatever it is.
Or oftentimes, if they do have, posterior involvement, they get treated, you can suspect, cataract progression may be in this future. Right?
Sure. So case number 2. 54-year-old Hispanic female presents with grittiness, light sensitivity, and moderate discomfort in her left eye. Her medical history is significant for hypertension and asthma. Recently she had mentioned that she was bitten by a tick and was awaiting test results. So she's a 54-year-old Hispanic female, grittiness, light sensitivity, moderate discomfort in the left eye. She does have hypertension. She has asthma. These are the things she knows of. Recent tick bite, and she's awaiting test results. Anything else that we'd like to know? I guess when was, when did the problem start and when was the tick bite? If the tick bite was after the start of the problem, we can cross that off, right? I think so. Any differentials? Right, Lyme. And then how do we counsel this patient? And of course, uveitis as a diagnosis for her ocular state, but how do we counsel this patient on the diagnosis?
Well, with Lyme, they'll be on antibiotics for a couple of weeks. So it's going to be a long, drawn-out process. And depending whether they're in their first stage or systemic stage, they may have other systemic problems too that you'll have to involve the primary care doctor. And
is Lyme something that you take your medicine for 2 weeks, like you do for a cold, and you get better, and that's it?
Well, like I said, you're on it for a couple of weeks, and the patient needs to be aware of that.
And then that's it forever? No sequelae from Lyme disease over a lifetime?
Well, it can reactivate.
It can,
Yeah.
it can. That's part of it too, is that this is where you are now, but this is a long road ahead, sure. How do we treat this patient? Well, we manage the eye. We let the doctor who did the testing for the tick bite, we let them know that the patient also has uveitis in whichever eye, that we're managing the eye, and their next follow-up with us is whenever it is. And if they would be so kind as to send a report of their findings back to you as well, as you've done for them, so that you know what's happening. Are there any treatment pitfalls in managing this patient? All the same ones for the previous gentleman apply here. With the
Risk of recurrence.
yes, that's the thing. With the risk of recurrence around sequelae of Lyme. Okay. Number 3, a 60-year-old African-American female presents with a history of previous bouts of anterior uveitis in both eyes. Her medical history is significant for diabetes, hypertension, and sarcoidosis. With regard to her ocular history, every time she has a uveitic episode, her intraocular pressure becomes elevated. And you can have a patient that's new to you, but the condition is not new to them. And they give you a very good history of what's been happening with them every time this happens. And they know more or less what they need. Yes, I need drops for the pressure and for the inflammation. Anything else that we'd like to know? Any differentials come to mind? I did not hear most of that.
Because I would just like every time you want to ask if
Yeah, that's the thing.
Right.
You
Yeah.
know.
It's worthwhile to mention if they're on any glaucoma medication because they're aware of their history spikes.
Mm-hmm. Is this a uveitic glaucoma patient that how often? Every time I have a uveitic episode, well, how often are these things happening? We know it's happened before in both eyes, or she knows it has. How often? Well, this is happening a few times a year. This is somebody who probably needs to be managed for both the inflammation and the pressure on a long-term basis. You try and minimize the recurrences by keeping them on some type of anti-inflammatory therapy. You follow them up appropriately to watch for the side effects of that, and you give them something to manage the pressure so that if they do start to have an episode, well, it's not going to impact the pressure too much before they come back to you. Counseling her on her diagnosis, everything that we've already said about uveitis, except in this instance, uveitic glaucoma. It's a sneaky thing, very sneaky thing. And we've seen a gentleman, I think I mentioned already, who in Jackson Heights, years ago, he was a 0.6 cup in the eye that has uveitic glaucoma. And as the years went on, because he would come back, he would not come back every time due to he lost insurance. He'd sometimes stop taking his anti-inflammatory drops. But we had him on anti-inflammatory and IOP drops daily, just because we saw that, hey, this guy's progressing little by little. We don't want to risk, he has frequent recurrences. His pressure goes very high during those recurrences, and he's high enough that it's doing a little damage for him. So we want to have him on drops every day because it's not really predictable when these things would start. But he was not consistent with his follow-up and all that. Over the years, he went from a 0.6 to a 0.95, 995 in that eye. And he's in his 50s. He's otherwise healthy. He'll probably outlive his eye. So it's something to be very vigilant about.
Any other pitfalls in this case that you want to look out for?
All the same ones apply.
Yeah. I know in this case the patient probably has sarcoid, but other patients may be on other immunomodulators once they're diagnosed by the rheumatologist. And at follow-up, you want to inquire, okay, so you saw the rheumatologist, they said you have condition A, B, or C, are they putting you on any medication? Many of which, have at-risk side effects too.
Sure. So a 24-year-old Caucasian male presents with a complaint of bilateral red eyes. He mentions his eyes are painful, watery, and he has excessively blurry vision. These symptoms have been going on for the past few months, but due to lack of insurance, he didn't come in. So his systemic health history is unremarkable up to this point. So this has been going on for a few months. Watery, blurry eyes, painful eyes, and it's been going on for a few months. So any thoughts about other things that bits of information we need to fill in the puzzle a little bit? Anything else you want to know? Any differentials come to mind based off that history?
Are the symptoms on and off or constantly getting worse?
I mean, we can assume constant. It's not specified, but
A lot of times when patients say their medical history is unremarkable, it helps to ask, when's the last time you've been to the doctor? And then ask them the questions that their partner would ask. Do you have joint pain? Do you have any gastric issues?
Any other symptoms?
An unusual marching in your skin? And unusual rashes?
But many times you'll ask people, do you have this? Do you have that condition? They'll say no. When's the last time you went to the doctor? 5 years. So the real answer is I don't know. It's not no, it's I don't know. That they don't know what they have at that point. And in terms of treating or counseling this patient, I mean, the presumption here is that he's got a bilateral uveitis. Bilateral, we have to really think that there's something systemic going on. It's going on for a few months. Definitely start managing the ocular component to it, but I would get him back into the system. He's been unplugged from the system for a while due to lack of insurance. Get him back with a primary doctor. Get him, make sure that they know the situation. They'll do the appropriate workup for him and hopefully uncover what's happening.
In terms of management pitfalls, again, we said, just assuming that if their medical history is unremarkable, it's because they've actually been to the doctor. To know that.
Right. Anyone have an interesting uveitis case that they've seen?
I had a uveitis case, and within 2 to 3 days, it just kept getting worse, and it actually was a herpes symptoms virus. I think it was there, but it wasn't present the first time I had seen it. And it came out after a few days, and it just wouldn't improve with the steroid. That was a complication.
Yeah. That's why it's considered one of those masquerades. Yeah.
That's why if you see that, any corneal changes, even the tiniest SPK, anything, a little haze, anything with that unilateral SPK, I'm sorry, with the unilateral uveitis, I would start assuming that there's a hepatic component there and start treating it. Yeah, that's the same thing we said. Absolutely.
And in terms of ordering blood work, our online docs also agree that if it's chronic, if it's bilateral, if it's more than the first occurrence, blood work is warranted.
Sure. Sure. Any other interesting uveitis cases anyone seen? You will. One day you will. Any other questions coming through online? We'll give a little time for that.
We'll give some time for that. We'll see if any questions come through. One of our online doctors, is mentioning a pretty interesting case. They had a patient with a bilateral granulomatous uveitis, history of recurrent sinus infections. They were HIV positive. After having a workup done with their primary care doc and further eval, they actually had a chronic lymph node infection.
Oh wow.
Yeah, but it took meticulous, careful follow-ups to tease that out. So a lot of times you'll send a patient off to rheumatology and everything comes back negative. It's a difficult question to say, okay, which of these are false negatives?
Right. And it's just like the primary doc refers the patient to different specialists. The different specialists don't usually refer to different specialists, right? They're expecting the primary doc to go back to take care of that role. So if you think of yourself as the primary eye doc, you might send the patient to the rheumatologist who does their battery of testing and sends them back to you as negative. It doesn't mean that that's it. We don't do anything. Rheumatology didn't find anything. Well, there's the retinal doctor you can send them to. There's the uveitis specialist that you can send them to. And then there's also the primary doctor that you can also pick up the phone and say, listen, we don't know, there's something happening. It's not responding the right way. It's not rheumatologic. They need further workup, and then the primary doctor can get involved as well at that point.
It doesn't hurt to ask for, repeat testing. That's a very interesting case.
Yeah, I'm thinking of a lady that we had in one of our offices. She had bilateral panuveitis, and We didn't know why. We sent her to a rheumatologist. Everything came back inconclusive or negative. She was not consistent with follow-up with us. She was not consistent with her medicine. She was not consistent with referrals, that we tried to send her on. Long story short, after about maybe 6 to 8 weeks of this, she came back with, decreased vision. She had bilateral exudative macular detachment, and, what do you do? I mean, it's something that we tried at each step to send her where she's supposed to go. She didn't go. So somebody asked a question online before that, what do you do with people who won't take your recommendation about where to send them and when we should follow up and all that? In short, as you can communicate as well as you can, not everyone will hear it the same way you're saying it. It just is what it is sometimes. But, you document everything as best that you can. You try from your end. Don't just send them out with a note and say, call this doctor, on Monday. You have your staff make the appointment from your office.
Right.
It's already in their system. Now, if somebody no-shows, well, they're partly responsible because you made the appointment. The other office called to confirm the appointment. They didn't go. So.
Yeah, if you're concerned the patient may be non-compliant because of lack of understanding or lack of access, it does help to communicate directly with the doctor you're referring to, either with a consultation report or request, and stating what you're thinking about, what you want to rule out.
Right.
That way, if the patient doesn't take the initiative and makes the phone call, the primary care doctor or rheumatologist can then reach out to them directly.
Sure.
Or you have your staff make the appointment for them.
Which I like to do too. But
As far as like to send out a letter to them.
sure. If you think that there's a risk of vision loss or something, irreversible, yeah, sure. Sure. I mean, you have to document as many ways as you can document that you're trying to do the right thing, sure.
Nothing yet so far, but as responses come in, I'll mention it to you guys.
Okay. There you go.
Yeah, thank
So,
you.
Thank you, guys. Very good. Thank you so much.